Jharkhand Ophthalmological Society. It gives immense pleasure to welcome you all to this leadership development program, and I extend a warm welcome to all to this leadership development program. And I am especially welcome all the office bearer of the JHOS, moderator of the today's session, Dr. Deval Biswas, and all the chairperson of the today's session. And a special appreciation to our young dynamic presenter of today's session, Dr. Devika Joshi, Dr. Soumya Ganesh, Dr. R.C. Singh, and Dr. Seema Rajan Singh, who will be sharing their perspectives on the different dimensions of the leadership and the thoughtfully chosen topics, whether leaders should be feared or loved, or whether leadership stems from the head or the heart. It promises the stimulating and the insightful discussions. And the leadership in ophthalmology goes beyond clinical excellence. It involves vision, empathy, communication, and ability to inspire teams and brings about meaningful change. So I encourage all the participants, especially the PG who have joined, to actively engage in the discussion and make the most of these academic opportunities. And I'm also delighted to inform that the two best discussants of the today's session will be awarded, which will further motivate the active participation. So with these words, I once again welcome you all and wish the session a great success. Thank you. So welcome all.
So I'm going to introduce the subject. So during our postgraduate training in ophthalmology, we mastered diagnostics, we learned surgical steps and built academic knowledge. We learned how to read an OCT, interpret a pentacam, calculate IOL power, and somewhere an important question remains. Are we being trained to lead? Because very soon, a PG is no longer just a learner, but a decision maker, a communicator, and a team leader. In emergency situations like acute glaucoma or ocular trauma, we need clarity of thought and confidence in action. While counseling a fearful patient or handling a post operative dissatisfaction, we need empathy, patience, and communication skills. While working with our team, optometrists, nurses, counselors, we need the ability to guide, coordinate, and inspire. And when we step onto the platform like AIOS, presenting, teaching, and representing our institutions, our societies. We need presence, confidence, and leadership identity. Because ultimately, ophthalmology is not just about microsurgery, it's about macro impact. This is why Leadership Development Program LDP is not optional, it is essential not only at AIOS level but at state level also. And with this, we are going to start. And we have Dr. S.P. Jakhanwal with us, the Honorable President of Jharkhand State Society, the Secretary, Dr. Sujay Samanta. Uh, we have Dr. Mala Verma, the Honorary Treasurer of JHOS. And we have Dr. B.P. Kashyap. He is the past president and ex-MC member from JHOS. So now I am going to introduce the AIOS ARC chairman, under whose leadership we are conducting this program. Professor Sunil Kumar, share. He is professor at HOD, Rio Rims, Ranchi, Jharkhand. He is the medical director, government eye bank and chief cornea services, Rio Rims, Ranchi. And he has been trained in PGI Chandigarh, and he has teaching experience more than 17 years. He has a lot of papers who he published by him, and he had received a lot of awards which you all can see on the screen. So now
The PowerPoint is not being shared. I think it's
Slide is not there.
it's the folder is open. Probably you need to change the share screen to slideshow option.
I'm doing it. Is it visible?
No, ma'am.
Not yet.
Yeah, no, it's on. Yeah.
Is it visible?
Visible.
Yeah,
It's
it's
visible.
visible now. Yes, ma'am.
He has taken the Rio rooms to a new height, and they have all shifted to the new building of the Rio Rims, which is magnificent, and their work is also magnificent. He's heading
Yes, ma'am.
cornea services. So, with this, over to Dr. Sunil Kumar to introduce our most dynamic and witty lady ophthalmologist of India, and Dr. Doel Vishwas. So, please introduce Dr. Doel Vishwas.
Yeah, thank you, ma'am. So,
We are sharing screen.
okay.
Is it visible?
Yeah, now visible. Okay, so thank you, ma'am. So the today's moderator, Dr. Doel Biswas. She is a cataract and refractive surgeon at Susruth Eye Foundation Research Center, Kolkata. And beside the refractive surgery, her passion lies in creating out-of-the-box programs like pentathlon, ophthalmic steeplechase, tall tales, walk the talk, the nation wants to know, and so many like that. And with her razor sharp wit and quick repartee, she is known to hold the audience spellbound during a program. So I welcome Dr. Doel Biswas ma'am for the moderating this session. Thank you. And next, I will introduce our Dr. Bharti Kashyap ma'am. So, ma'am, slide please. Ma'am's introduction slide. Yeah.
Dr. Sunil, you can be short for
Yeah.
introducing me. Yes.
Will you share the slide? Slide is not visible.
Slide is not visible. Okay, wait. Is it visible?
It is started. Yeah. Yes. Now it's visible. So I
Be
will
short.
introduce our own Dr. Bharti Kashyap. She is the founder director Kashyap Memorial Eye Hospital and medical director Kashyap Memorial Eye Bank. And she specializes in the femto cataract and refractive surgery. And she is the first woman ophthalmologist of the India who has been awarded and felicitated with the Nari Shakti Puruskar Award in 2017 by none other than the Honorable President of India. And she has held so many positions like Chairman Scientific Committee, JHOS, Chairman Women Doctors Wing IMA Jharkhand, Secretary Women Ophthalmology Society Jharkhand, and she is the ex-national co-chairperson Women Doctors Wing IMA
I
in
think this is
Kolkata.
enough. Now I
Yeah,
am
and
going to introduce, yes, going to introduce our esteemed chairpersons. That's Dr. Sophia Ahmed. She is the
yes,
HOD of Ophthalmology, Bokaro General Hospital. Dr. Bharti Sharma, she is the HOD of Ophthalmology, Tata Main Hospital, Jamshedpur. Dr. Seema Kumari, she is the senior faculty of MGM Medical College and Hospital, Jamshedpur. Dr. Nidhi Gatkar is the head of the cornea services, Kashyap Memorial Eye Hospital. Dr. Anindya Anuradha is HOD of Bhagwan Mahavir Manipal Hospital, Ranchi. Now over to Dr. Nidhi Gatkar to introduce the guest faculties, Dr. Simar, Dr. Arshi, Dr. Devika, and Dr. Soumya. So over to Dr. Nidhi. Is she here? Okay, if she's not there, Doctor, okay, she's there, but she's muted. So please share the screen. Is it visible? आपने ज्वाइन किया है? आपने ज्वाइन किया है? Dr. Sunil, am I audible? Dr. Sunil,
yes, ma'am.
We can, once she joins, she will do, we were starting, I'm starting with Dr. Simar Rajan
Yeah,
Singh.
we can.
He's
Yes, we
associate
can start the
professor.
talk. Yeah,
He's a
I,
associate professor vitreoretinal surgery and
yeah.
advanced eye
Now
center.
Dr. Nidhi has joined. Dr. Nidhi has joined. I think we can introduce.
Okay.
Only the
Good evening.
folder is visible, the slide is not visible.
Every time you are doing this.
Ma'am, when you go onto your share screen mode, just open the one with the presentation and not the window. That's it.
My expert person is with me. I don't know what is the problem today.
Yes, now it's visible.
It's not visible.
It is visible,
It
ma'am.
is visible. It's visible.
Okay. Dr. Nidhi, please brief because we have 3 sessions to conduct.
Okay. Good evening, everyone.
Be short.
I invite Dr. Simaranjan Singh, who is the Associate Professor of Vitreoretinal Surgery at Advanced Eye Care, PGIM at Chandigarh. He has done his Master of Surgery with a silver medal from PGI Chandigarh and has also done a fellowship in vitreoretinal surgery. He has been awarded the Professor Nam Perumal Swamy Young Researcher Award and Oration in 2025 by VRSI. He has also been awarded the NIH Award by the National Eye Institute USA for his work in pediatric retina at the Advances in Pediatric Retina 2023 meeting in California. He has been awarded the E.T. Selvam Award and the Hanumant Reddy Award, Professor I.S. Jain Memorial Silver Medal. He has been the winner of the AIOS quiz. He has also been awarded the Best Postgraduate Thesis Award from AIOS in 2017 and has over 110 index publications and several faculty talks to his name in the field of pediatric retina and vitreoretinal surgery. Welcome, Dr.
Nidhi?
Simaranjan.
Okay.
Yes.
Dr. Simar, you can start your talk. In the meantime, I request Dr. Nidhi to be a little brief for the introduction because we have to listen to Dr. Doyle also and we have to finish the session on time also.
Yes,
So,
please.
Dr. Simar, over to you for your presentation.
Thank you, ma'am. So
Mr.
this
Leadership
is going to be a
Talk.
debate. This is going to be a
Yes.
debate, right, ma'am?
Yes. 3 minutes.
So probably you can introduce the other speaker also, ma'am, so that we can give the talks back to back.
Yes. That's what I was planning. Dr. Nidhi, please back to
Okay.
back karo.
Right. Our next speaker is Dr. Arshi Singh, who is the Assistant Professor, Glaucoma Services at Guru Nanak Eye Center at MAMC, New Delhi. She is also the section in charge of DOS Times and member of DOS Young Surgeons Subcommittee. She has received the IGO Platinum Award and DOS Achievement Award, and she is the executive member in UOC. She's the team leader for UOC Glaucoma Focus Group and is the
Is this
managing
audible?
editor for Yo
Is
Times.
this visible, the slide?
It's
Yes,
visible.
it is visible.
Okay.
So,
Okay.
welcome, Dr. Arshi Singh.
Next.
Our next speaker is Dr. Devika S. Joshi. She is the honorary consultant at Dinanath Mangeshkar Hospital and Research Center, Pune, and has a private practice in Pune. And she is a NB postgraduate ophthalmology teacher. She has several publications in index journals, and she has presented various national and international papers at various conferences, including APO, AIOS, POS, Spectrum, Moscon, WOC Barcelona, etc. She has also performed live surgery at the POS annual conference. She has been a member of the managing committee, and she is the editor poster for POS from 2021 to 2023. She has completed her AIOS LDP from 2025 to 2026 and received a DAD scholarship for international travel program from Max Muller Bhavan, Pune, and Goethe Institute Mensa Scholar. Welcome, ma'am. We welcome Dr. Soumya Ganesh Naina, and she is the former honorary secretary in IMA Virajpet. She has done a fellowship in cataract and refractive surgery from Narayan Netralaya. And she has got various awards like the Ophthalmic Entrepreneur of the Year 2024 from WAS. She has been the winner in IRSI Women Power Special Online Symposium, International Ophthalmic Hero in 2021. She's got various awards at WOC 2020, APACRS, AIOS, ESCRS, APACRS 2013. And she has been a speaker at many national and international conferences. And she has reviewed a lot of publications and textbook chapters on cataract surgery. Welcome, ma'am.
Okay. So now back to back, we will take up the presentations. So is Dr. Arshi, has she joined, Dr. Arshi?
Yes, ma'am, I'm right here. I have
Okay,
some
Dr.
network issues.
Devika, Dr. Devika.
Yes, ma'am.
Okay, so we will start with Dr. Simar. Then his pair is with the Arshi. Leaders should work with head. Then leaders should work from heart. The Dr. Doyle, can you moderate the session now?
So shall we start?
Yes.
So we are starting with Dr. Simar, right? And he's going to speak on the subject.
You are not audible. Doyle, you are not audible.
Can you hear me now? Because I'm unmuted.
You are unmuted now. I can hear you, but it is not a very clear voice.
I have my thing on the maximum. Can you hear me now?
Yes.
Okay. So am I audible now? Loud and clear?
No, not very clear, but yeah, you are audible.
Okay. So Dr. Simar is going to speak on how a leader should be led by the brain. Now, this is a very, what should I say, a very juicy topic, because we know in life, it is very simple. Till you are married, you are led by the heart.
Ma'am, you're not audible. Your volume actually is very low. If you could come closer.
Can you hear me now?
Yes, I can hear you. You are audible, very loud now.
So, as I was saying, that in life it is very easy to know when you're led by the heart and when you're led by the head. Till you're married, you're led by the heart. The heart takes all the decision. Once you are married, the brain takes over, the heart is given a rest, and you are led by the brain, and that's when you realize what a mammoth mistake you have made. But when it comes to leadership, it's really difficult to decide when you should be led by the heart, when you should be led by the head. So Dr. Simon will throw more light on that. Perhaps at the end of it, we will know exactly when the head or when the heart. Dr. Simon, all over.
Thank you so much, ma'am. I hope I am visible and my screen is visible right now. So I'm going to try and make a case for brain-led decisions in healthcare leadership. So I would like to point out here what we are talking about is actually decisions for your organization as a leader, and not particularly patient-related decisions as the physician for the patient. So if you look at that, yes, compassion is really important as doctors, and thinking with the heart is really important. And we are trained with compassion to deal with the patients. But the motion before today us is not whether compassion matters. It definitely does. There is no doubt on that. The question is how the leader in a healthcare system should make decisions while taking into care his organization and the society. So strong leadership in healthcare, why the head over heart? The leadership requires objectivity. You can't let emotions drive your decisions. You need evidence based, just like we have evidence based medicine. Your decisions need to be evidence based. You need to have protocols. You cannot be there for the organization at all times. If you have certain protocols in place which are based on evidence, they can be implemented even when you are not right there present all the time. But if your emotions are guiding those decisions are going to be different every time. So you need to have some objectivity in your decisions. And then again, healthcare resources are limited for us, especially in a country like India. These resources are always going to be limited. So you need to kind of triage out what needs more priority based on the evidence rather than just thinking with the heart and okay, this patient is suffering more, maybe I need to help him more. So you need to have some objectivity again in those decisions. Leaders also must think long term. You need to have a plan in place for 5 years, 10 years, where you see your organization to be. Immediately, a single patient suffering, thinking with your heart may not be the best decision for that. This is just an example in an eye care setting. If you're in an eye care emergency, you have all these kinds of patients that are there in front of you. You always take decisions think based on triage and kind of trying to categorize them that what needs urgent, what needs urgency, and what can wait. So again, these are brain-led decisions. These are not heart-led decisions. The person with cataract might be your relative, but you would still want to wait on them and treat a retinal detachment or open globe injury on a priority or an endophthalmitis on priority rather than going for the lesser severe spectrum of the disease. So this is just an example of brain-led decisions. And this debate is always going to be there, whether the EQ is more important or IQ. EQ is becoming more and more the talk of the town. And yes, empathy is required when you are dealing with your staff, you're dealing in the organization, but it does bring in personal bias and a certain amount of emotional overload. Brain-led decisions might lead to some cold decisions, but in the long run, they are logic-based, they are knowledge-based, and they are repeatable. Most important, you can apply those principles again and again. So just my final slide, balanced leadership is integrating both the head and the heart. You need to establish a clear vision for your organization, what you want over a longer period of time. Cultivate empathy and communication between the staff, but when it comes to your decision making, it has to be informed decisions based on certain statistics, and you need to hold accountability for everybody, including yourself, for those decisions. Thank you so much. Over to my other debater, Dr. Arshi, please.
I think that was a brilliant presentation, Dr. Simar. But I will just sum up. I think two of the things that I took from your talk was that number one, like India, we cannot afford too much of heart. That is one thing. And the other thing is that keep your heart for your staff. When it comes to your, it's more of the head. And I would also like to make one observation that in everything that you have said, do we see a sort of a male, tendency that males have less of a heart as compared to a woman? Well, let's go to Arshi and let's see what she has to say about this. Arshi.
Absolutely, ma'am. So I'm going to be talking about this topic against it. So I'll be talking about how to lead from the heart, and I'll share my presentation now. Let me know if you guys can see my screen. Is my full screen mode visible now?
Yes, absolutely. We can see it.
Absolutely.
Yeah,
So Dr. Simar just talked about the fact that leaders should work from the heart. And I'm going to discuss, from the head. And I'm going to discuss about why the heart actually builds people and head builds the systems. We're not going to be talking about ophthalmologists and how they should function. We're going to be talking about how ophthalmological leaders should function. So that's where the difference lies. Why does the heart matter? People who work for you will work well and work hardest when they feel valued and cared for. It's the emotional commitment that actually drives their effort. And always, when you're a compassionate leader, that builds loyalty and trust because people want to feel cared for by their leaders. That is why it really happens to matter a lot, especially in medicine. Why? Medicine is not purely analytical. We are dealing with human beings. Human beings are patients who require compassion. And also the human component in terms of our workforce, our residents, our workforce, people who are working under us need mentorship, and teams need psychological safety. So a leader who uses their heart to inspire people is going to always be beyond the ordinary, right? For example, in medical colleges, I'm going to talk about what I see because that is what I practice. You have great teachers. Why are they great? Because they believe in their residents. They guide them through their tough times, through their tough surgeries. They also encourage them after failures. They invest time and effort in their growth. They stay late beyond hours, which is beyond their logic, beyond what their brain tells them to do, because this is leadership from the heart. You don't always select the smartest. Your brain will tell you select the smartest, the hardest working. You have to teach all of them. You have to give all of them opportunities and make them all grow to their potential. And often they'll surprise you. The people you think weren't really great come up because of your mentorship and because of the tutelage that you have put them under, and they will shine. So that is what leaders do. They bring people up. In ophthalmology, there are so many examples of leaders who have led because of their passion. For example, the Arvind Eye Care founder, Dr. Venkataswamy, then the founder of LV Prasad Eye Institute, my own institute, Dr. G.N. Rao. You ever talk to him, you'll understand how passionate he is. He's leading from his heart. Definitely the brain is there, but it's the heart that's leading. Then again, Dr. L.P. Agrawal, the one who was the mentor for most of them, most of the AIS leaders, they all are leading because of their passion and from their heart. That is where it all starts. And there are people who changed the world. You all know these names because they are so famous. Nelson Mandela, Mahatma Gandhi, Mother Teresa. What do you hear about them? Were they the smartest leaders? Were they famous because of their IQ? No, they were not Einsteins. They are people who have been known because of the way they chose peace, moral courage, reconciliation, service, and love over everything else. And this is why they became people who actually changed the way world functioned. Again, let's not talk about just about past examples. Let's talk about evidence. Evidence also shows that because of leadership results, employees give their best to leaders who care. Emotional connection increases performance. So this has been studied by multiple studies. This is just one of the books that actually talks about this because it teaches leaders how they should work. And that's how I also have been trying in my journey because I'm passionate about my branch, about teaching. So this is something that I started. This is our WhatsApp group. We are taking a lot of initiative for teaching our residents as well. And also teaching in a medical college means that I get to interact a lot with the young ones and understand why a lot of times teaching from your heart and leading from your heart makes all the difference. So, dil se re, do what your head tells you, but ultimately lead because of where your heart is telling you to go. So the head manages the system, but the heart inspires the people. Yes. Thank you so much for your patient listening.
To quote you, Dr. Ashish, that was a very passionate talk that you gave. However, in the end, you balanced it by saying, the heart and the head. I just have one question. When it comes to the battle of the head and the heart,
I usually go with my heart.
Go with your heart. Before we go to the other speakers who will be on again topics that are opposing each other, I would like to go to the discussants. Discussants, please remember there is an award for the best question or the best observation that you make. And it's a mighty award, 1,000 rupees for the 2 best discussants. So who are the discussants? Are all of them here? Would any of you like to ask a question from either of the speakers? Dr. Anamika Chaudhary, are you there?
Yes, ma'am. Yes, ma'am.
Anamika.
Yes, ma'am. Yes, good evening, everyone present here. I would like to add up to this in the present scenario where everything is very diplomatic and very practical. Is it needed that we have a good balance between both our heart and the head, or there should be more importance given to the decisions leaded by heart or by head? So should there be an amalgamation between both the things, or just one thing dominating the other?
But to answer this, I'm not going to go to any of the speakers because obviously they're going to say one.
Yeah, yes, ma'am. Sure, sure.
I will go to the panelists here. Can I ask one of the chairpersons to answer this? Dr. Bharti Sharma, ma'am, could you please tell us?
Bharti Sharma, are you here?
Dr. Bharti Sharma here?
Dr. Sophia Ahmad, you can ask. Dr. Sophia.
Yes, I heard their talks. They were both are very interesting. But the question she is saying that there is should there be amalgamation between heart and head? So this totally depends upon the situation you are handling. So at times you have to use only your head, and you have to subvert your emotions, and at
Yes.
times you have to work with your emotion. I think this is what I got from
Yes,
it.
ma'am. Absolutely. Very, very true, ma'am. Thank you
I'd
so
like
much.
to add something. Like, we often calibrate our leaders who are loved, empathetic, and approachable. But I think when when applied ethically and strategically, it can drive discipline, respect, and results. So that's
Yes,
very
ma'am.
important. You have to mix both of the elements. It's very important in a leader.
Before that,
Yes, ma'am. Thank you so much.
discussant to please come up, ask a question. See, unless you ask a question, you are not eligible for the award. So come up with your question, come up with your observation.
Vatsala.
Ma'am, the voice is very low. I don't know.
No,
Could
it's
is
okay.
it
It's
for
okay.
everybody?
No,
It's okay. Pragya, you have any question? You want to say something? Pragya Chauhan?
Good evening, ma'am. Good evening, everybody.
Yes, Vatsalan. Yes.
I just have a question. Many a times we come with a situation that ask whether we should act by heart or by mind. So how can we balance it? Because I heard both the perspectives. Both the perspectives were nice in their way.
To tell, what do you feel? You lead. You
The
tell.
thing that the point that I took, ma'am, is what Arshi ma'am said at last, that the head manages, but the heart thinks.
Not agreeing to what your head is saying, or if your head is not agreeing to what your heart is saying, what are you going to do? You have a situation, your head and your heart are colliding with each other. Your heart tells you something, your head tells you something else. What are you going to do?
Can I add something? I think you should go with your gut then.
Yeah, there are so many critical situations when you face during emergency duty. What to do?
And at that time, your previous experience also counts. So that by that you learn what you should do.
Yes.
Should you act with your heart, or should you use your only your brain?
Ma'am, if I may add something, we have been told to debate. It's actually not a debate at all. It obviously shows that you really have to use both of them. It's about what proportion
Yeah.
plays a greater role. Like Doyle ma'am said, if you were in a challenging situation, what would you choose? So that kind of differs for the kind of leader you are. And that is what they teach us, what sort of leader are you? What are your driving forces? And everyone can be a different sort of leader. It just
You know
depends
what?
that you need to be
I will
an
tell you-
efficient leader.
I will tell you one situation. Long back in 2001 or 2000, there was an eye donation call in the middle of the night, and it was in at Jonah Fall area. It was some 80 kilometers from Ranchi, and I had no driver, and I was just thinking. From my mind was saying, "Don't go," but my heart was showing, "This is an eye donation call. You should go." Then I applied my mind and I asked the Prabhat Khabar people whether this guy who is saying that he's a reporter, whether he's really a reporter. They said he is really a reporter and genuine person. So I followed my heart, but I used my mind to find that this person is.
Verify.
So we should proceed further to the next pair debate.
Proceed to the next topic and maybe come back to the discussions later. So the next topic we have Dr. Devika Joshi, and she's going to talk on, again, a very, very debatable topic, and it says, should leaders be feared? That is something that, we probably don't want to talk about, and leaders don't want to claim that they are feared. But the honest truth is, leaders are more often than not feared. So should they be feared? Does a little amount of fear actually help in leadership? And we have Dr. Devika speaking on it.
Yes. Shall I start? My screen is visible, I hope. I thank Jharkhand Ophthalmological Society and Bharti ma'am for this opportunity. Should a leader be feared? So recently I read a book called Porous, which is a trilogy. It's up on how King Purushottam defended India against invasions by Alexander. And in that, this is a old picture depicting King Philip II being assassinated by his own bodyguard. So he was a very democratic leader. He was friendly with his neighbors. He had many collaborations, but he was brutally murdered by his own bodyguard. And at that point, Alexander took reign from his hand, much to the distrust of all the generals and the common public. And he was then perceived as a boy prince. So he exalted a lot of fear. He exterminated people who were coming in his way, and he started by attacking Persia from the port of Halicarnassus. So those who didn't support him were exterminated, and that is how he became a leader, by initially exalting fear amongst all the people. So these were very different leadership styles. I mean, his father and Alexander. So in recent years, we have a very loved leader now, but in his initial years, he was very demanding, very intense. He was feared, but that's what took Apple to the height that it is today. So initially, when we are also learning, especially during residency, we fear our teachers, our HODs, because we'll have some punishment. But I think ultimately it's because we need to be good surgeons, good doctors, that they exile fear in the initial few days. So there are many affirmatives to this. There is more reliability over emotion. There's a dread of punishment. It increases the efficiency and discipline. And if a leader is hated for the correct reasons, then ultimately the goal is achieved by the team. So like in Chak De India, there's a dialogue by Shah Rukh Khan that her team में एक ही villain होता है और वो मैं हूँ. So that ultimately resulted in a very cohesive team, and they could achieve their own goal and be happy about it. So usually what it is very effective in crisis or emergencies. And in some management terms, they say 20% fear is what keeps the team on its toes, and it discourages laxity, and it gives consistent standards, and it reduces favoritism. There are some cons to it. It is not a very sustainable leadership model. It doesn't last long, and people start leaving the team. There is a lot of talent drain. Good people start leaving the team, and then it kills the creativity and innovation that is there in the team. And also, usually a leader who is feared is also the last to know about some problem, some bad news in the team. So there's an information vacuum that is there in the team. So I think a balanced authority with empathy is what we need. We need to set high standards, but without intimidating the team, and build trust for a long-term success. Striking a middle path is what is more important. And I think great leaders are respected more than feared. Like how Simar said, we can use our brain in critical situations, exalt fear to some extent, but leaders like Mahatma Gandhi, they are more respected and not feared. And people may comply with fear initially, but they commit with respect. So if you want a team to go ahead and forward, what you will really need is respect. And don't do unto others what you won't do to yourself. Thank you.
Brought out a very, very point where you said that sometimes fear eventually turns to respect, because there's a very thin line between fear and respect.
Yes.
That was really the point that came out of this. But we have Dr. Sonia, who says more than fear, it is the love which makes a good leader. So again, the heart coming into play. Soumya, over to you.
A very good evening, respected colleagues, esteemed panel. I see some students here and some dear friends of mine from my previous LDP batch. A very good evening to all of you. We are gathered here today not just as doctors, but as leaders. And today I stand before you to strongly support the motion that leaders should be loved and not feared. Just give me a minute, my slide isn't moving. Right. So Niccolo Machiavelli in The Prince famously posed the question of whether it is better to be loved or feared as a leader. He suggested that fear may be more reliable, but that was the politics of the 16th century kingdoms. We practice medicine in the 21st century, a profession built not on control, but on trust. In ophthalmology, leadership is not about authority alone. It's about vision, quite literally and metaphorically. A leader who is feared may command compliance, but a leader who is loved inspires commitment. When a surgical team fears the head of the department, they may follow instructions precisely, but may hesitate to speak up. And in our field, hesitation can cost vision. In contrast, when a head is respected and loved, the operating room becomes a space of psychological safety. Questions are encouraged, complications are discussed openly, and outcomes improve. We all know of the work of Atul Gawande, who emphasized that high-performing medical teams thrive not because of rigid hierarchy, but because of open communication. Leadership in healthcare extends beyond our teams to our patients. A feared leader may run an efficient clinic, but a loved leader builds a healing environment. Some may argue that fear ensures discipline, But discipline rooted in fear is fragile. The moment the leader leaves the room, standards slip. Discipline rooted in admiration and shared purpose is self sustaining. Think about it. In medicine, the mentors we remember most are not the ones who terrified us in ward rounds. We remember the ones who corrected us firmly but kindly. The ones who made us believe we could be better surgeons than we ever imagined. Love in leadership does not mean weakness. It does not mean lack of standards, and it definitely does not mean avoiding accountability. A loved leader can still be decisive. A loved leader can still demand excellence. A loved leader can still take tough calls. Let me leave you with this thought. A leader who is feared may be obeyed in their presence, but a leader who is loved is followed even in their absence. As ophthalmologists, we restore sight. As leaders, we provide vision. And vision is clearest when it is not clouded by fear. Thank you.
I think you again put a lot of much, Soumya. But having said that, isn't that a very thin line between fear and respect?
Yes.
And do you think that without that essential element of fear, no matter what, love alone is not enough to be a leader? If people love you but don't have that slight amount of fear mingled with respect,
Yes, I think what the problem sometimes is that we may not be able to communicate in a way that is understood by people. So when we are not able to communicate, like for example with children, if we are not able to communicate a point or the child is not able to understand what we are saying, then after a while we just get frustrated and then we start yelling at the child. So sometimes the problem may not be about fear, but it might be about about being able to establish that communication between you and the other person. And sometimes there may be generation gaps, they just may not be able to grasp what we're thinking. So I think that is the first step in establishing that. And we always come from a position of more understanding as we become seniors, more understanding, more knowledge. So they will look up to them. They will look up to their professors or leaders or seniors as long as they know that they are being understood as well.
Now, both of you, I have a reputation. Can't hear me? Can you hear me now?
Yes.
Yes, yes, I can hear you.
So both of you, I have a reputation to uphold. Okay, I am known for being a brat. So I'm going to put both of you on the spot and ask you a question, which I want you to answer honestly. Name one leader in the AIOS who is feared. Go on. Name one leader. So
I could not hear you.
Dr. Bharati Kashyap, because she always knows what she wants and she won't take no for an answer. So I would say it's both inspiring and I don't think you want to mess with Dr. Bharati Kashyap. I think you want to be careful about, what you say to her and meet her expectations.
Get to solve. Your statement is just one thing. The one leader in AIOS who is feared is Dr. Bharati Kashyap. Period.
Oh my God. Oh my God. Oh my God.
Can you tell us one leader in
maybe the AIOS midterm discussion in the WAS group has affected her.
That's why she's the Nari Shakti Award winner, right?
Yeah, I know, seriously.
Another leader, please, from the person who spoke on fear being an essential commodity for leadership. I want you to name one leader in the AIOC who is feared. AIOS, rather.
It's a very difficult question, honestly.
Have to say.
I don't think there is.
Namrata Sharma.
Dr. Bharti, that was
no, honestly, I think none of the leaders are very fearful. I mean,
Namrata Sharma.
If we say none of the leaders are to be feared,
although I'm contradicting myself,
saying that we do not have good leaders because you said that a good leader has to be feared. So when
so
AIOS are to be feared, are in essence saying that the AIOS does not have any good leaders. Do you agree with me?
So I think, I mean, we are speaking about leaders, but in context of fear, it is important to fear the consequences of wrong actions. But I
Correct.
think it is
Correct,
important to
correct.
fear
You
the
are so
positive.
right. You are so right. Your name Devika. You are so right that the leadership is that you can evoke that sense of fear in the other party, that the consequences of your wrong step is going to cost you dearly. You are right. Very nicely you put it up. Because and another thing, the one leader who is very affectionate, but he is a leader. I can tell you, I have personal experience. One leader who leads, but he's in through a very affectionate way. That is a Dr. Mohan Rajan. Yes, because I have seen him at so many situations. But Dr. Devika, she has really expressed in a very nice way. Uh, a good leader should create that feeling that if you are doing something wrong, you should be aware of the consequences. Right.
We have come to
And one thing, ma'am, it's very important to assure that whether the fear is ensuring compliance at the cost of creativity. That is very important.
Yes.
There you have to check, because if you are like creating a fear and it's affecting the creativity, then the
Yes.
ideas might not
Yes.
come up. That is
Yes.
very important. And
Yes.
also it's very important to assess that whether that fear that is being created, is it creating a short term order, or a very long term resentment is being created.
Yes.
So
But
that
I
is going
think,
to affect
yeah.
the work atmosphere where we are working. So it's very, very important to take this all these things into consideration, and creativity is very, very important here,
Yes.
because even the juniors can come up with very good ideas. Many a times they do give some suggestions that are very effective,
Correct.
effective in clinically and academically also. So this is something where we need to gauge the situation.
I
So this
think
is
Doyle has to give cash prizes to us. So I should please invite the PGs, otherwise we will end up taking the prizes.
want some man, some boy to speak up. It's all the voices I have heard, except for Dr. Simar, has been female voices. So I really
I know. I end up working with women only. And there's so many boys. Please.
want Dr.
Gagandeep, Irshad.
Dr. Ishad is not there.
Dr. Irshad is very anxious because he's going to face Sugneshwari in fishbowl.
Then do we have Dr. Shubham? Do we have any male there?
Mayank,
Mayank. कुछ तो
Amar, kahan hai sab? Where are you all, bhai?
Gagandeep.
Come up with questions.
Well, I think you were one of the first ones to come on board. I saw your name right at the beginning. Dr. Ujwal, are you there?
Yes, yes, good evening, ma'am. Good evening, all.
Can you say
Ma'am,
something on this topic? Please do so.
yes, ma'am. I totally think that both love and fear, if if it is, if it is in a very positive way, then it should overall the individual's development should also happen, and the work of the institution which you are there, that should also happen properly. So it is like you have to be aware that you are not responsible only for you. You have your institution, your prestige of your institution, and means that's all I have to say.
Any boy? Gagandeep?
And yes, ma'am. Well, in our hospital at Kashyap Memorial Eye Hospital, we have great love from our consultants,
No, no, you
and
don't have
of
to
course,
name.
we fear them. Yes, ma'am.
You don't have to name anyone. You give the situation.
Right.
You
Give
Love
your
and
give
fear,
some situation.
both in hand, actually works better.
But if you don't have a choice, you have to choose between you are a leader and you are given a choice, you lead by fear or you lead by love. What
Yes.
by?
Yes, batao. You will lead by
But
fear.
personally, I would be led by love, though. Personally.
You will be led by, no, you are going to lead.
Well, if I am to lead, then I think love would be a better path, since
Why?
fear withers away. After a while, the staff stops fearing you. The staff would rather be in contempt rather than actually be be productive. And love would actually keep on building it on. If you care for your staff, if you care for everybody, then actually it builds up. Even when you are not there in the hospital, even if you're not there any at your place of command, that love will actually keep people going on. That's what my opinion is about the matter.
Okay, anyone else? Any other?
Uh, Good evening, everybody. I want to add something to it. So basically, I cannot talk about others, but I can talk about myself. So I'm a junior resident third year. So I have two set of juniors, JR2 and JR1, beneath me. So when I asked my senior, ki, ma'am, I'm going to be a JR2, how should I deal with it? So they said, ki, Vatsala, jaisi ho, waisi hi rehna. You have, so that is what I do. I set a fine line, but I teach my juniors. And there is a scope for open communication because I communicate with each and everybody. And if a junior does something wrong, I just go alone, take her or him, take her to a room, and just tell her that you have done something wrong. And if you would do this in the future, then your juniors would also do the wrong thing, and that is bad. So basically, I tell them that you are wrong and you should not do this again. I don't scold them, but at least they should know that they have done something wrong, so they would not repeat it. So as ma'am said, that open communication is important, but also a fine line should be there. Otherwise, they would not respect you. So that's all from my side.
Love
Uh,
Fear
Ma'am,
actually
I
needs to
would.
be applied very ethically and strategically. That is very important because you have to maintain the discipline also, you have to gain the respect of others also, and you have to get the results also. That is, therefore, fear should be there. A fine balance is required in between both. That is very, very important.
Yes.
What I feel
And
in
ma'am, I
our
would like to add something is that uh, as ma'am quoted the example of Chak De India, and we all know that at the end, the leader who was feared the most was also loved the most by all the team members because he actually guided them to receive something and achieve something which gave them a recognition and also guided their way. So ultimately, the leaders who are feared the most, at the end, we find that they are only loved the most.
Yes, Anamika, you are right, because I have also seen this in my hospital.
Yes,
Actually,
ma'am.
my husband is feared the most, and I think he's loved the he's
Sir is also loved the most. Yes,
yes,
ma'am. Of course.
yeah.
True.
you are right. How come you have so
Yes,
much of
ma'am.
wisdom?
that.
Ma'am,
Add to that. If Dr. B.P. Kashyap is feared the most, there is many more feared. I shall not mention the name, but I'm sure you can all can come to the conclusion who is the one person that Dr. B.P. Kashyap fears the most and of course loves the most. Name does
Yes, ma'am.
Realize this over the
Everybody
years.
knows the
Ma'am,
answer.
I'll tell you something. Summing it all up, is there any other discussion to something because you have an award? The last chance you're getting.
ma'am, I would also like to add, like Dr. Soumya ma'am said, quoted an example of Atul Gawande's book. In that book, he was very professionally active before being diagnosed, and after being diagnosed, he was very means lovingly behaved with his patients, and matlab, so means proper way of uh, being in a matlab, in a professional uh, standard is not totally cut to cut defined. So it just depends like which matlab, what is best for you, and like it should not affect your students or your teachers. matlab, it should be, it means you matlab, there should be a proper way and adjustment. Thank you.
Very nice.
nicely said. I think we will wrap this up, but before we wrap it up,
Yes.
two things based on all the four deliberations. When it comes to heart and the head, I think it's a really difficult choice, and every day, every and as a doctor also we face this. And however, I do feel, and perhaps you won't agree, we women do have a slight tendency to be led by the heart in some of our making decisions. Men, I think, are much more pragmatic. And then coming to the leader who is loved and feared, I don't think we need to go any further than Dr. Bharti Kashyap. Believe me, when I or when anyone first sees Dr. Bharti Kashyap standing there, the regality that she has about her, for a moment you do like you take a step back. And then, if you are very fortunate, like I am, to come to know this lady closely, to become her friend, you will realize that she's like a coconut, hard on the outside and soft in the inside. So I think Dr. Bharti Kashyap is a perfect blend of fear and love. And that's what I think in many of our leaders we find, when we see them from a distance, there is this element of fear which comes maybe out of the reserve that they need to have, the 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 attitude that they need to have in order to be leaders. But as we get to know them, as we come to see more of them, we probably discover that behind that sheen of that reserve, that fearfulness that's there is a lot of love, to guide you and to help you, and a lot of compassion. So can we end up on that note, Dr. Bharti? Did you hear me? No, I can't be heard.
Heard you, and thank you so much for such a great compliment. And you have to announce the best discussant's name.
I have two best discussants, and they are, I think, Dr. Anamika and Dr. Ujjwal. And one of the reasons why I have selected them is that they were the most vocal of all the discussants, and they were the ones who actually came forward a second time. First time I chose, second time they came forward on their own, their heart. So I think the two of them would be the two best discussants.
Correct. And
Thank you, ma'am.
They were sincerely hearing the program, whole program. They were involved in it.
So you have to wind up and say word to Dr. Sophia.
Okay. Very good evening to everyone once again. It is my privilege to propose a vote of thanks for this inspiring leadership program. And on behalf of Jharkhand Ophthalmological Society, I would like to thank our esteemed speakers who spared their precious time enlightening us with the discussions on a very powerful question: do leaders work with heart or head? And should they be feared or loved? So I thank Dr. Somya Ganesh, Director of L Drishti Eye Hospital, Dr. Devika Joshi, Senior Consultant in Dinanath Mangeshkar Hospital, Dr. Arshi Singh, Assistant Professor, Glaucoma Services, Guru Nanak Eye Center, MAMC, Dr. Simar Rajan, Associate Professor, VR Surgery, PGI, Chandigarh. So, what we learned from them is leadership is not about choosing one over the other. Your leadership is impactful only when you think with clarity and you have a goal and then act with compassion. You have to develop trust and good interpersonal relationship, interpersonal connections to be a good leader. And then I thank our moderators, the very able and such a nice discussion she put up. She is none other than Dr. Diol Biswas from
the most wittiest among all.
Witty and yes, very energetic discussion. And Dr. Sunil Kumar, RIMS Ranchi. I extend my thanks to respected JHOS office bearers for organizing this webinar with a difference under the able leadership of Honorable President Dr. S.P. Jakanwal. And we especially appreciate the untiring effort of a chairperson, scientific committee, the very dynamic Dr. Bharti Kashyap and a team. And we appreciate the initiative taken by Dr. Sunil Kumar, chairperson, ARC JHOS. I thank all the students and colleagues who have joined this webinar to make this more meaningful. In the end, on behalf of all the members present here, we thank the entire Entot Pharmaceuticals for their complete coverage and support with the audiovisual. Thank you.
Thank you so much. And I wish if Doyle can be with us during the fishball session, because this is we are doing its first time.
We'd love to have her there.
Yeah. Yeah, we love, and every time you have to conduct, be the moderator of our this leadership development session, because nobody else than you can fit this role of moderator for leadership, because I find you the wittiest time and again. So thank you so much, Doyle, and thank you all the leadership development program speakers. So now we are going to start our Retina CME session. This is the second session, and we are just beginning the exciting and academically enriching session on the preferred practice pattern in retina diagnostics. We are truly privileged to have with us our eminent national guest faculties, Dr. Subina, Dr. Sugneshwari, Dr. Purna Chandra B, Dr. Pratyusha Gani, who bring immense expertise and experience in the field of retina. What makes this even more special is that they are also the experts leading our PGs in the fishball session on retina, and a highly interactive and dynamic learning platform. And I must say with great pride, this is the first ever PG fishbowl session by the Jharkhand Ophthalmological Society, and this is the brainchild of Dr. Shweta Walia, again one of my very close friend, CSC of Madhya Pradesh State Society. I am confident that this focused priming on retina diagnostics will not only strengthen the fundamentals of our postgraduate students, but also empower them to actively engage, think critically, and derive maximum benefit from the upcoming fishbowl session on retina. So, and we have our JHOS office bearers with us, Dr. BP Kashyap, the past president of Jharkhand Ophthalmological Society and MC member. We have Dr. Rahul, our Suja Samanta, our secretary, Dr. Sunil Kumar, ARC chairman, then Dr. SP Jakhanwal, the president, Dr. Rahul Prasad is the joint secretary of JHOS, and he is heading the VR unit of Rio RIMS. Dr. Vibhuti Kashyap is the MC member from JHOS and member East Zone ARC AIOS. Dr. Archana Kumari is the head of Vitro Retina Surgery, Prasad Eye Hospital. Dr. Abhishek Patnaik, these are the chairpersons. Dr. Abhishek Patnaik is the VR consultant, Tata Main Hospital, Jamshedpur. Dr. Divya Prabha is the senior resident, Rio RIMS Ranchi. I think they all have joined and respected the state platform. And Dr. Ritika is the VR consultant, Gita Shri Retina Institute, Ranchi. Dr. Divya Prabha, Dr. Ritika, are you here? Dr. Divya Prabha and Dr. Ritika, Dr. Abhishek Patnaik, Dr. Archana, have you joined? Dr. Rahul?
Yes, ma'am. Yes, ma'am, I'm here.
Okay.
Dr. Archana is here, ma'am.
Okay. So, Dr. Abhishek, Dr. Divya Prabha, Dr. Ritika, because I have also to see that every time their photo is flashed on the flyers, time and I'm circulating, and they are not even taking half an hour time out. So Divya Prabha and Ritika are absent. Dr. Rahul, are you here? Because
yes, ma'am. I'm absolutely here. I've been here since the very
yes,
beginning.
yes, I can see.
Yeah, sir is there. We have been able to see him for quite some time. He's there. Sir is there.
And ma'am, congratulate you on the first session, ARC session. It was wonderful, ma'am.
And all because of this Doyle's wittiest mind. And so over to Dr. Rahul Prasad to introduce the eminent speakers. They are all national faculties and they are going to teach they have taken time out so from their busiest schedule. So please introduce them all so that one by one they will present. So Dr. Subina, Dr. Sugneshwari, all of them are such big people of retina, a star of international retina, rather, I will say.
Very good evening, ma'am. And it's my honor to introduce Dr. Suvina Naran. She is a vitreoretinal specialist. She has a number of publications in her bag. She has done her fellowships. She has received a number of numerous awards in national and international conferences, including Nursing Rao Award 2011. She has been an honorary secretary of FICO 2021, Outstanding Ophthalmic Teacher of India from FOTI in 2023, and multiple travel grants. The post holds are member managing committee AIS from 2017 to 2020. She has also been honorary secretary, Chandigarh Ophthalmic Society. Now, coming to our second guest, that is Dr. Sugneshwari Ganeshan. She is a senior consultant.
Is the screen visible?
Yes, ma'am. It's absolutely visible, ma'am. Dr. Sugneri Ganeshan, she is the senior consultant professor of ophthalmology. She is from Shankar Nethralaya, Vitreoretinal Service, Vitreoretina and the Oncology Services. She has done her vitreoretinal fellowship from Shankar Nethralaya. She again holds the position of leading intraocular oncology department of Shankar Nethralaya. She is the project director of Lions Skill Transfer Training Program. Her principal interests includes diabetic retinopathy, ocular oncology, and intraocular infection. She is a great academics, great reviewer. She has a number of she has been a guide to number of theses, trained 35 cataract surgeon across India in 2 months to diagnose, perform laser and intravitreal injection for diabetic retinopathy. She is a co-investigator in Dream's study, published more than 60 articles in peer-reviewed journals and 4 textbooks. She has served as a co-investigator in many international clinical trials related to diabetic retinopathy, choroidal neovascular membrane, and retinoblastoma. Slide, please. Of course, Dr. Punarchand B, he is a vitreoretinal consultant from Department of Electrophysiology and Clinical Genetics, Narayan Nethralaya. He has been associated with many Jharkhand academic activities for last couple of years. He has completed post-graduation from the prestigious AFMC Pune and followed by a long-term fellowship in vitreoretinal surgery from Narayan Nethralaya, Bangalore. He has undergone additional training in inherited retinal disorders and electrophysiology from the most famous Moorfield Eye Hospital, London. He has completed his preparatorship on age-related eye diseases from Safe Sight Institute, Sydney. Presented several papers on national and international forums, has published many articles in peer-reviewed journals, has won several awards, including Rima Mohan Award for Best Paper Retina at AIOS and Best of IGO Awards. His area of interest includes inherited retinal diseases, electrophysiology, retinal vascular diseases, and gene therapy. Welcome, Dr. Punachandra. Next slide, please. Is it hello? Yeah. Yes, ma'am. So, our next chairperson is Dr. Pratyusha Gani, and speaker is Dr. Pratyusha Gani. She has done her MBBS from BMCRI Bangalore and MS from JIPMA. She has done her long-term fellowship from Arvind Eye Hospital, and she is working as an additional professor at AIMS Mangalore. European Vision and Eye Research Foundation Fellowship at Cardiff University 2014 she has completed. Medical Retina and Cataract Fellowships, which is sponsored by the Royal College of Ophthalmologists UK between 2015 and 2016. She has received her ROP training at LBPI Hyderabad in 2024. She has almost 60 PubMed indexed journals, publications, and she has also almost 4 chapters, book chapters, the presentation, numerous presentation at national and international conferences. Her area of interest include imaging in retinal diseases, diabetic retinopathy, and artificial intelligence in ophthalmology. I welcome Dr. Pratyusha. I mean, Dr. Divya is also over here, ma'am.
Yeah, I think some network issue is there. So I think, sir, my voice is not audible.
Yeah, we're getting you, Divya.
Okay.
Ma'am, you're muted.
Dr. Ritika, are you here? Because this is a retina session. So now, Dr. Rahul, please, they should start.
Yes,
So
ma'am.
with Subina, Dr. Subina, then Dr. Sugneshwari, then Dr. Purna, and then Dr. Pratyusha.
So I'll request Dr. Subina to kindly start with a slideshow.
And what a national faculty we are having today for our postgraduate students.
Are my slides visible?
Yes, ma'am, it's visible, ma'am. It's visible.
All right. And I'm audible, right?
Yes, ma'am, you're audible.
Yes.
At the outset, I would like to thank Jharkhand Ophthalmological Society for having me over here on the topic, which is very dear to me, retinopathy of prematurity. The learning objective here would be, let's understand what is the big challenge we are facing, the infants who are at risk of ROP. Then what is the screening criteria in India, the classification of ROP, and the treatment of ROP, a brief overview I'll give, and follow up in cases of ROP. We must understand that India has the highest number of preterm babies, 3.5 million, and ROP is a potentially blinding disease for these immature retinal vessels. Preterms at risk of developing ROP are around 2 lakh, and of these, around 20,000 go on to develop treatment requiring ROP. Each baby requires repeated visits, and we are just handful of ophthalmologists who are trained to or who are interested in doing ROP. And all these babies have to be followed up till the time retina fully matures. So thus we want people to join hands in screening of these babies so that they can be referred at appropriate times. Now, who are the babies who are at risk of ROP? The Neonatology Forum of India gave the guidelines. They said all the babies with gestational age of less than 34 weeks and birth weight of less than 1750 grams. And this would increase to 36 weeks of gestational age and 2000 grams of birth weight in case risk factors are present for ROP. Apart from gestational age and birth weight, we have a whole lot of risk factors like multiple birth, outborn babies, respiratory distress syndrome, acidosis, PDA, etc., which could add on to the to development of ROP. In our study, we found that double volume exchange transfusion was the single independent risk factor for development of ROP. Screening is fairly easy, can be done by anybody who's trained in retina. And this has to be, the baby has to be dilated with diluted phenylephrine and tropicamide. 2 drops have to be instilled and at 20 minutes interval, wipe the excess because our skin also absorbs these drops and these could be detrimental to the health of the baby if you are putting more drops. The only thing required is the eye speculum and wire vectis. Wire vectis is for globe rotation and these babies have to be swaddled properly and you should do your initial examination in NICU setting so that any kind of abnormal, because once you are depressing the eye in the beginning, as you learn ROP, you would need help of pediatrician in case some untoward incident happens. When to screen for ROP, it's a beautiful slogan given by Dr. Subhadra. 30 din roshni ke, that means within the first 4 weeks of postnatal age, the baby should get the screening for ROP. If your neonate is less than 28 weeks of gestational age, birth weight less than 1200 grams, then we prepone everything by 2 to 3 weeks. The median age at detection of stage 1 ROP is roughly post-conceptual age of 34 weeks. And in fact, as I said, there are just handful of ophthalmologists who are trained to do ROP or who want to do ROP. Then what we are doing is that lots of NICU and SNCU nurses are trained to take pictures of these babies with red cam, 3 netra, and now we have even mobile loaded the cameras on the mobile phone. They can take at least 5 images should be taken, the center, the superior, inferior, temporal, and lateral, which would be sent for teleophthalmology. And then the documentation of ROP must be done. The extent of ROP should be documented as what zone of retina it is involving, and the severity is as for the disease of ROP. In fact, because of the medical legal implication of ROP, we must document whether the patient was dilated or not, and when does the patient come back again. We should give the date to the patient. Now, zone 1 ROP is with the disc at the center. You draw a circle twice, the radius is twice the distance between the disc and the macula. And the outer than this zone 1, you have 2 disc diameter area. This rim is posterior zone 2. And then from the nasal ora serrata, the rim temporal to out of zone 1 is zone 2. The temporal crescent which is left behind is zone 3. So we must know which zone of ROP are we dealing with, because that tells us whether the baby is to be treated or baby is to be referred at what interval. Now, in a busy setting, it is very difficult to say what is zone 1. The best is having a 28 diopter lens. If your disc is at the rim of the field of view, what you are seeing, whatever you are seeing is zone 1 ROP. And for stage, if you have a demarcation line between the vascular and avascular retina, this is stage 1. And if you do fluorescein angiography, you just see a hyperfluorescence flat demarcation line. The moment this line gets subvolume, it becomes stage 2 ROP. And it is not that fluorescein angiography is essential to diagnose stage 2, but it is just showing you what exactly is happening. You have capillary tufts posterior to the ridge in stage 2 ROP. In stage 3, you have fibrovascular proliferation, which is in fact standing like a wall. So this is stage 3 ROP. And on fluorescein angiography, there's intense leakage. This is the time you have to treat these babies. Stage 4A is once the retina gets lifted up, it is not involving the macula, it is stage 4A. Stage 4A B will be when fold of the retina is involving the macula also, and macular detachment is there. Stage 5, these are the images taken from ICROP3 classification. And 5A is once the disc is visible, total retinal detachment. 5B, the disc is not visible, total retinal detachment. And in 5C, you have anterior segment changes. You have shallowing of anterior chamber, iridocorneal touch, which is stage 5C. Aggressive ROP is something which need not be missed. I mean, you have to see very carefully. You have to pick, if you have such dilatation and tortuosity, you should not miss these flat neovascularization. If you see this flat neovascularization, they skip stages. They progress straight to stage 5. So these babies need not be missed. And this is here where anti-VEGF agents really work very well. Plus disease is very important. This is basically dilatation and tortuosity of vessels. Now, this also has undergone change in ICROP3 classification. Earlier, it was so much of dilatation and tortuosity in all 4 quadrants. In fact, pupillary rigidity could be there, vitreous haze could be there. Now, with ICROP3 classification, it is that plus disease is a continuum of diseases. I mean, continuum of pictures. It is not just full dilatation and tortuosity. It could be something which is more than normal. Then beyond that, you have pre-plus disease. Then still more tortuosity is plus disease. So, and this also gave us the concept of notch. The notch is once in the temporal part, in the middle, you see that there's notch. So this zone of ROP is the spherous zone, which is there. And here it is zone 1, secondary to the notch, which is present here. So once you have all this, you know that you have zones and stages. Now, what is the ROP you're going to treat? Type 1 ROP is the high risk pre-threshold ROP which we treat. Here you see that all in red needs to be treated. So once you have plus disease, any stage you need to treat in zone 1. Stage 3, even without plus disease, you need to treat. They are high risk pre-threshold ROP. And in zone 2, if you have plus disease, stage 2 and 3 is what needs treatment. Others are low risk pre-threshold ROP, which you have to keep on close follow-up. In our study on fluorescein angiography, we found that if you have to predict which of the type 2 ROP are going to go on to type 1, that means treatment requiring ROP, it is the ones with delayed arterial filling and ones with popcorn lesions. They are the risk factors for progression of type 2 to type 1 ROP. The treatment of ROP has undergone major change. It started in 1986. It was cryo, which was done for the avascular retina, changed to laser treatment with ET-ROP when they were doing diode laser for their babies. We are doing, in fact, 532 nanometer laser only. You have to target the growth factor now. Now the trends have changed from laser or cryo to anti-VEGF agents. With the coming in of BEAT ROP trial in 2008, they said, yes, bevacizumab has good outcome as compared to laser. 0.625 milligram in 0.025 ml was what they had given. And you follow a safer strategy. That means use soft needle, antisepsis follow-up, close follow-up. You can go ahead with treating these babies with anti-VEGF injections, which are 1 millimeter from the limbus you inject, and ranibizumab, aflibercept have also come up for these treatments. But most of us are usually giving the combination of treatment. Now, so this is a baby, ROP baby. The macula is hardly mature in this baby. Once you do FFA, it is very clear that macular vascularization has not developed. So you don't want to laser the avascular retina here. The macula will go away. So what you do is you go ahead with anti-VEGF, let these vessels grow. And once the macula has vascularized, you go ahead with lasering whatever avascular retina is left behind. That gives good visual outcome to these babies. When to call these babies again, just touching on if it's just the avascular retina, zone 1, call them after 1 week, zone 2, call them in 2 weeks, zone 3, call them in 3 weeks. In case ROP has developed, then it is 1 to 2 weeks you need to see these babies. In case it is ROP in zone 3, you could go ahead with 3-weekly follow-up. Otherwise, they have to be seen in 1 to 2 weeks time. In case you've already treated the baby, if you've done laser treatment, then first examination is usually done 2 weeks to look for skip areas. After that, the patient can be on longer follow-up examinations because it's a lifelong follow-up. I'll just show you how it can affect later on also in life. But in case you have injected anti-VEGF agents, then these babies are on 1 to 2 weekly follow-up till the time the whole vascularization is complete. Recurrence is typically known in after these anti-VEGF agents, so we have to be on the lookout. In fact, 8 to 12 weeks after that injections, they do go ahead with the recurrence. So we have to identify that recurrence, which would be dilatation of vessels again, and you have to treat at that time. Now, this is one latest study which has come in 2026. It says that type 2 ROP go ahead with dexamethasone eye drop, which could decrease the progression of ROP. But we have to do, I have no experience with this. We still have to go ahead with this treatment. We have to explore it more. Surgical consultation are in case your ROP has not been treated in time, it has progressed to stage 4A, 4B, or 5, you go ahead with surgery. And past vena plicata vitrectomy or lens sparing vitrectomy is what we do in these cases. Here, doing little is doing a lot. In these little eyes, you just have to cut the basic traction forces, ridge to ridge traction forces, ridge to lens or ridge to zonal traction forces have to be cut. Don't change hyaloid in these cases. You don't have to go ahead with, removal of the hyaloid. And these 4A, the results are very good. Stage 5 results are not as good. It is pretty dismal. But so we have to prevent the babies to go to stage 5. Follow-up of ROP is lifelong. It is not that I have treated, that's okay. It doesn't work like that. So this is, you go ahead, these babies are more at risk of myopia, strabismus. Babies not going to tell you have to see whether the baby has refractive error or not. So they have to be initially 3 monthly examination, then 6 monthly, then yearly examination, lifelong is there. It is seen that vision related quality of life in these children, even the parents, the quality of life is affected, and most field which impacts the vision related quality of life is having strabismus, not just having glasses. It is the strabismus and amblyopia, which is bad for these parents. ROP requires dedication, precision, perseverance, patience, long-term and lifetime follow-up. Once you see these babies achieving a lot or being now they are, in fact, they are postgraduates also, you really feel great. They come back and tell you, well, their vision is saved. That's really gratifying. Increasing burden of ROP emphasizes the role of comprehensive ophthalmologists in screening of ROP, and treatment requiring ROP has to be referred well in time. Thank you. My special thanks to Dr. M.R. Dogra and Dr. Tracy, under whom I have been trained, and they are the stalwarts in the field. Thank you very much, sir, for giving me all the knowledge for ROP. Thank you.
Thank you, ma'am. That was an excellent way you described ROP. Ma'am, with your due, ma'am, I would just like to ask one thing, ma'am. Can you please share few tips for the beginners, especially the residents who are about to start ROP screening? What are the helpful tips, ma'am, from your side, your experience, you can share with us, ma'am?
It's the patience. In fact, I would say babies are the easiest to see. You wait, you just have to wait. The doll heads maneuver does the job many times. You may not even require the indenter or the wire vectors, because to begin with, we learned from Dr. Dogra. And we would say, okay, this is difficult. It's just you have to jump into the pool. The babies are very easy to examine. They rarely do not. You just have to wait. The baby moves the eye and you see temporal retina. Try seeing temporal retina first, because that's the most important part. So I think you would just have to jump into it.
And ma'am, while beginning the learning, ma'am, which lens would you like to advise, ma'am? Is it the 20 diopter lens or straight away going with the 28 diopter lens?
I would say 28 diopters, because zone 1 is what you should not miss.
Yes, ma'am.
So 28, it's easy to say, well, it's zone 1. Otherwise, you'll keep on thinking maybe you missed that or something. So I started with 28 diopters, so that was good.
Okay, ma'am. Okay.
Yeah.
Thank you, ma'am. And any other questions from the panelists?
Good evening, ma'am. May I ask a question, sir?
Yes, Vatsalap, go ahead.
Ma'am, I just wanted to ask, how can we be sure that we are at the aura or we can see till the aura in a baby?
In the baby, once you rotate the eye, you see avascular, you see the demarcation line beautifully, and then you see the avascular retina. Right? Hello?
Yes, ma'am. Yes, ma'am.
Aura, you would be able to see the aura. I mean, there's a differentiation. And once with your wire vectors you're rotating, you do see those processes and you make out like, well, this is the aura. What? And then after that, you see the ciliary body and all that stuff. I think it's easy. It shouldn't be a problem. You have to see it to believe it. Yeah.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Vatsala. Any other questions from for ma'am?
Yeah, hello.
Yes,
Am I
yes,
audible?
Divya. Yes, Divya.
Very nice presentation, ma'am. So I would like to ask you a couple of questions. One is, so I was usually I have given only Avastin injection in ROP baby. So what is your experience as Rajumab as an intravitreal injection in cases of ROP babies? And do you repeat the injection? And if you do, then what is the interval between repeating the injection?
Nice question. I work in a government institute, so we do not use off-label drugs, though people are shifting because the recurrence rate is lesser with Avastin. So people are shifting to Avastin, but in our institute, we are stuck on ranibizumab. We still give ranibizumab for these babies, and the recurrence rate is more, but the advantage is that the recurrence occurs early when the baby is still coming back for follow-up, 8 to 12 weeks. So you do get to see the baby. Definitely, if the recurrence will be there, you'll pick it up. And I never repeat, because I have seen, if you, even with one injection, the rate of growth of vessels stalls tremendously. 2 injections, they are definitely to just go in posterior zone 2, they'll be stuck there. So I never repeat my injections, and I think the study will be coming out with the study that do not repeat the injection because they really stop the growth of these vessels. So I haven't repeated.
Okay, ma'am. Thank you so
If
much.
there's recurrence, I would laser, but I would not repeat.
Yes, ma'am.
Okay. Thank you so much.
So please invite the next speaker, Dr. Rahul, please.
Yes, ma'am. Thank you, ma'am. And our next speaker is Dr. Sugneshwari Gopal Swami, and she will be presenting her slide in OCTA and helping us understand the delicate factors with concern with OCTA. Sugneshwari, ma'am.
At the outset, am I audible?
Yes, ma'am, you are audible.
Yeah. Good evening to all of you. I would like to thank the Jharkhand Ophthalmic Society for providing me an opportunity to be in front of all of you. And I have just now heard the wonderful lecture, the leadership program, and it was excellent program, I must say, and a lot of learning for me too from that program. So is my slide visible? Can you all see my
Yes, ma'am.
PowerPoint?
Yes.
Yeah, okay. So I will begin my talk on OCT angiograph. And first thing is for all of us is to understand a little bit about the history itself. Why the history is important? Because see, there are certain things which has evolved over a period of time. And if we don't understand history, I don't think we'll be in anywhere in between. And we should owe credit to all the people who have been innovators and inventors. So what we understand is this OCT is got a much higher resolution than the ultrasound or even the MRI. David Huang showed that multiple A scans could be displayed as a false color or grayscale image, that is a B scan, demonstrating the first OCT image in 1991. So what we had started initially as a concept and now where we have evolved to the commercial OCTA, which actually came in 2014. So we are going to see what exactly are the principles. So the principles are simple. It is basically on the interference pattern, and there are, you can see what is the interference pattern which is there, and it is an A scan at every point. So there are multiple A scans put together, that becomes the B scan. Now what you exactly see is the OCTA is actually we are talking about the representation of retinal vessels, but they are basically not the retinal vessels. What we do actually see is the moving retinal blood vessels within a predetermined range. That is what is important. So when you have a predetermined range, within that, whatever we study, this is called the motion. So it displays in vivo retinal vasculature in a depth resolved fashion. So, and what exactly happens? You have segmentation of the volumetric data, which actually leads to the identification of the retinal capillary plexus. So now if you see, this is what I had discussed is on the, basically it is about the motion contrast. So what happens is when you go through an A scan, it kind of detects the pattern when it is there, when there is movement of the erythrocytes, that is what is happening. So now when you have within the artery, within the vein, so within the artery, you have some movement happening. Within the vein also there are corpuscles which are moving. So now when these movements are happening, every A scan, because each as A scan has got a time lag. So these are multiple A scans taken with a time lag. And when these A scans are processed, that is what comes as OCTA signals. So you have one at T, one at T1, one at T2. This is what is the multiple signals that are being generated. So now what are the slabs that we have? So you have the superficial capillary plexus slab, you have the deep capillary plexus, you have choriocapillaries, you have the choroid. And then what you also see is if in a, sometimes when you are having a very good eye with a clear media, you may be able to see the choroid and sclera interjunction. And you kind of have the default slabs wherein the most important one is the VR interface. If you're talking about proliferations, one should concentrate on the VR interface. And if you are talking about, let's say about a diabetic retinopathy, one should pay attention to the deep capillary plexus slab because that is the first one to get affected, and even in a vein occlusion. Then you have the avascular complex, the choriocapillaries, and the choroid. So now, how do you exactly understand what are the layers that has been seen in the superficial capillary plexus? So you have the ILM, the GCL, the inner plexiform layer, and this is important for certain conditions like what when you want to see a foveal avascular zone, you please pay attention to the superficial capillary plexus. When you have a proliferative diabetic retinopathy, then you pay attention to the SCP and in a vein occlusion as well. And what about the deep capillary plexus? So the deep capillary plexus, you see it in the inner nuclear layer and the outer plexiform layer. And this is the place where one has to pay attention when you want to see about the vascular laws in the diabetic retinopathy. And what about the VR interface? So now, avascular slab. When you talk about avascular slab, this is the most important layer when you're talking about choroidal neovascular membrane, or the type 3 MNV is predominantly seen in this slab. So in this, you basically see the OPL and the outer nuclear layer. And next, we have the choriocapillary. So when you want to study about the ischemia in the posterior uveitis, one should pay attention to the choriocapillary slab. And now we move on into the ORCC slab. So now the ORCC is the most important slab because most of our patients who have neovascular membrane, choroidal neovascular membrane, or the type 1 MNP, you call it as, one has to pay attention to this slab. And so you are seeing the outer plexiform layer, the outer nuclear layer, and the choriocapillaries here. And what about the choroidal vessels? So the choroidal vessels are not clearly visualized. That is because the signals are blocked by the RPE and the overlying retinal layers. So this is one thing which you should kind of, predominantly we don't appreciate much of these things in this. And also we must understand with different machines being available, one should know which machine stands for what and when would you order. So when you're talking, I don't have any financial disclosure, though in Shankar Netralaya we have all the machines which is listed here available, but every machine has its own capacity. And I believe everybody can kind of study whatever machines you have. Using that, every disease can be studied well. That's what I should say. So if you are talking about a spectral domain OCT, you can have the size cirrus, which is 5,000 or 6,000, wherein it usually performs around 68,000 scans, or the 100K, that is what. And you could get a 3x3 or a 6x6 or a 12x12. And if you are using a Zeiss Plexi Light, in this you get the maximum scan as of now is available with the Plexi Light that is there. And if you are predominantly trying to study about the choroid, then one would definitely look into the SSOCT. But apart from that, if you are trying to study about diabetic retinopathy or a vein occlusion, I am sure the SDOCT also is phenomenally very good. So now these are the different machines that are available. And now there are also protocol machines which are like going up to the depth of, but of course they are still in the research that goes up to 22 millimeters. So one day we are going to have an OCT machine which is going to give a study from the optic disc to the aura itself. So now this is how you get a TopCon and a Zeiss printout. And one should understand the segmentation. So segmentation, why is it important? There is the automated generated segmentation is there, and whenever there is a pathological entity, many a times one should also resort to manual segmentation. So you must pay attention to the segmentation. Otherwise, we may be ending up, dealing with a wrong understanding. Sometimes even a PED could be interpreted as an MNV. So these are certain things one should pay attention to. So the VR interface is the first one which you should see, where the segment has happened, and the superficial, the deep, the avascular, the choriocapillaries, and the choroid. So as I had described initially, so the segmentation should happen at that particular location only. Now, how do we go about really doing this? So first, the clinical examination, nothing can go against clinical examination. You need to see which is the area of interest that you would like to do, and you will first see the NFAS image, see the structural component, see the vascular slabs, and pay attention to the segmentation, and then finally to the OCT-B scan and the flow signals. So this is how you must, see your or read your OCT. So now image the right spot, look at the NFAS OCT image, which you can see here. These are the NFAS images which comes first, and then look at the segmentation lines. So it should correspond to the anatomical structure where it should be, because in pathological thing, there are movement of lines which can happen. So one should pay attention to that. Then look at the B-scan overlay, which is there. And you should also look at the NFAS intensity image as well. That is a final one. So if you are wanting to read about the OCT nomenclature, this is a consent-based recommendation. This article is good for all of you to go through. And you must understand that certain things in OCTA, certain words are not to be used, because people try and use, flow void and flux and things like that. But that is not the thing in OCTA. So what should be the words that should be used? Either you say the signal intensity is increased, decreased, absence, or present. This is how it must be. So now I'm going to show you OCTA picture in which you see there is a 6 millimeter by 6 millimeter NFAS SCP slab. You can see what I said, decreased signal. So when you say decreased signal here, so there is a non-perfusion, at the FASF. So now what does this actually mean? So when you have non-perfusion, you see that as a loss over there. So now in certain situations, what you can also see is there is some mild increase in intensity of the signal there. So when you see that, one should understand that there is probably something happening, that is vascular remodeling, or it could be a neovascularization. So when you see a structural OCT, so when you see an OCTA B scan here, now you kind of see this is at the boundaries of the MCP and the DCP. So in that, when you see a hyperreflective area, then that could be a sign of an intraretinal neovascularization, or even it could be a neovascularization in the MACTEL type. So now here, what are you exactly seeing? I've marked the circles which is the area of interest here. So what does it exactly see? So this is a superficial capillary plexus flap, and that you kind of see there is an increase in signal. So this How do you know that it is a microaneurysm? That is basically because it is because of the location. So one can identify things on the basis of the location of the lesion. So now the next most important thing is also one should pay attention to the artifacts. So what are the artifacts that one should pay attention to? Because the time scale, I told you there is something called as a decorrelation signal. That is because of the time lag which is there. So when you kind of, take multiple images, there are a lot of artifacts that happens. So these artifacts are like motion artifacts, the projection artifacts, the segmentation artifacts, the suspended screening particles in motion. So we call it SSP. So these are all the things one should concentrate on the masking. So these artifacts, you should know to identify them, otherwise it becomes difficult when you interpret. So now to say the what I've shown it as a motion artifact, this is a blink artifact, and you also have a doubling artifact. So these are all certain artifacts one should pay attention to. Now, if you want, sometimes we do what is called as a DR protocol, where we try to stitch multiple images. So this is taken by, this is called montage, where you kind of stitch around 5 images together. So in these kind of protocols, you tend to have stitching artifacts. So this is something one should pay attention to. So now if you see, this is a plexilite image. So in that you have the multiple slabs which are shown, that is the 3x3, and then you have the 6x6, and then you also have the 12. So you can also have the 15x9 as well. So now, apart from that, you should pay attention to the signal intensity. Now you can see where you would like to see your signal intensity. If your signal intensity is somewhere less than 6 and all, it is not very acceptable. So that is called as image quality metrics. So one should pay attention to that as well, because if you don't want to have a poor quality image and then use it for reading. So now, why do we really need OCTA? So where do you actually require it? So most important thing is on patients whom you could not do an FFA for reasons like patient has got a kidney disease, you will not be able to perform an FFA. But believe me, OCTA is kind of replaced FFA in many of the disease modalities. Very few are the areas wherein one would require the use of FFA. But I am sure FFA is not going to become depleted. It's not going to go away, because it is still going to have its own use. So where does OCTA have its usefulness? It is a non-invasive detection, and it is useful in detecting the morphology of the MNV itself, and you can monitor the response. In diabetic retinopathy, very useful to see the FAZ enlargement, the capillary dropout, the neovascularization mapping. In retinal artery or vein occlusion, you could map the ischemia, see for the collaterals and the new vessels, and uveitis or the white dot syndromes. You can detect the inflammatory CMV and the choriocapillary flow deficits. And of course, in glaucoma, you could see the peripapillary and the maculovessel density, and you could use in the inherited retinal diseases to quantify the microvascular loss. And now to show a few examples here, you can see this is a type 1 MNV, which you can see. So when I say type 1, it is, of course, it is beneath the RPE. And when you have the type 2, it is between the neurosensory and the RPE. And in the type 3, when you are seeing, you can see that type 3 is, of course, many a times to be missed. It is just seen as a tiny bright area where you see that is what is most important, that is seen on the choriocapillary slab. And now about the choroidal vessels. So when you have the atrophy of the RPE, then you tend to see you can see the picture here. This is an atrophic atrophic RPE. So you tend to see more of the choroidal vessels. So don't think in terms of treating this patient, because you're actually seeing the hyperreflective choroid underneath, and no indication for an anti-VEGF. Now, moving on into what is called as an intraretinal microvascular abnormality. When you clinically see this image, all of us tend to think that probably we are dealing with a neovascularization. But what exactly is it a neovascularization? When you see these, when you see the slab, that's when you kind of identify that the VRI slab, or when you look through these things, you see the flow here. In that, it is not elevated. You see it within the neurosensory retina. You're not seeing it anywhere above the at the level of the VR interface. So that clearly it deciphers that we are dealing with an intraretinal microvascular abnormality and not a neovascularization. So when you talk about neovascularization here, you can see this particular patient, you can see the neovascularization, which is actually standing in front. But when you see the fundus photograph, all of us would predominantly miss it up if we are not carefully watching this. So, and in this patient, if you see very carefully, there is a tiny neovascularization in this patient as well. So now when you are talking about retinal venous occlusions, in occlusions, predominantly we try to observe the shunt vessels, which you see here, and the microaneurysms, which you can see, and also areas of the capillary non-perfusion areas. And in this, you can see the basically the volumetric analysis you can see, and of course on the B scan you can see the tiny cystic spaces that are there. This is a branch retinal vein occlusion involving the superior artery. So now when you talk about the FAZ, so when you see FAZ, you would like to see for enlargement of FAZ, or if you would like to know whether there's a stretch of the foveal vascular zone. And in these cases, it is pretty important that you see the vessel density, which is very much available, is parametric values. So that is pretty useful as well. And also you try to see whether it's a non-perfused or it is a stretched macula. So these are all the conditions one definitely would like to use. And in summary, OCTA is a pretty useful non-invasive tool, and it is useful in patients with comorbid conditions. And it is one thing that it is the most important thing one should understand, that it cannot detect a leakage. So you cannot use it in CSCR patients and try to do a focal laser. That is not going to be possible with this. You should understand the limitations as well. And it is an excellent device for monitoring, whether it is in macular neovascularization, or you would like to monitor an macular edema. And most important is to be cautious on the artifacts itself. So with that, I kind of conclude the talk on OCTA. So I would be happy to, take up questions.
I have a request, Dr. Sugneshwari. You people are international faculty. Everybody realizes that, but we will take questions after fishbowl, because all the retina people are. I am watching. So there are 52 people have joined by faculty link. And there are so many others also. So we will take questions later, because Dr. Shweta Walia has to go. She has small children. So we will take up questions later, Dr. Vatsala and all the PGs. So you will never get PGs like teachers like Sugneshwari, Purna Chandra, Dr. Subina. But rarely you get such teachers. So आप लास्ट में आप लोग क्वेश्चन पूछना. अभी हम लोग फटाफट टॉक्स खत्म करते हैं और फिशबॉल शुरू करते हैं. After fishbowl, we will keep a discussion part.
Okay, ma'am.
Thank you so much, Dr. Sugneshwari.
Thank you, ma'am. Thank you, ma'am, for the excellent presentation on OCTA. Next, I would like to call Dr. Punar Chandra. Now, Dr. Punar Chandra has been with us with JHOS educative program for the last couple of years, and he has been excellently in describing the electroretinogram. That is his favorite subject. So, Dr. Punar Chandra, please.
Thank you so much, Dr. Rahul.
क्या है, डॉक्टर पूर्णा ने अपना नया सीवी दिया है, तो अब ये बहुत बड़ा सीवी है, बट he has got best of IJO award, ASRS award, JOCR award, AIOS International Hero Award. Means he is the best international hero in retina. So a lot of international awards I can see. So it will take a lot of time. So we are proceeding to the talk.
Thank you, ma'am. Thank you so much. At the outset, I would like to thank Jharkhand Ophthalmic Society, especially Dr. Bharti Kashyap ma'am, for the opportunity. And thank you, Dr. Rahul, for the kind introduction. Hope my slides are seen in full screen mode and
yes,
my voice is clear.
They are there. They are there. Fantastic.
Okay, fine. Excellent. Okay, so my topic will be, basics of electroretinogram. I'll keep it brief about the basics, followed by case example, which are relevant to every ophthalmologist. Fine. So full-field electroretinogram is basically a mass response of the retina to a luminance stimulus. stimulate the retina with light or what pattern, there will be biochemical and ionic changes which happens in receptor and RPE, which generates electrical potential, which is recorded as electroretinogram. Fine. So there are different waveforms in ERG. The way we have PQRS in ECG, something called A wave, B wave, and oscillatory potential in ERG. The first negative deflection is the A wave, and it is from the outer retina, that is photoreceptor. So followed by a B wave, it is predominantly from the inner retina, that is bipolar cells, with some contribution from molar cells. If you carefully observe the ascending limb of B wave, there are some deflections here. These are called oscillatory potentials, and these are from amacrine cells. So when it comes to ERG, whenever we consider doing an ERG, first we should know what test to order. Okay, because ERG just not one thing. There are different types. So fulfilled ERG basically it represents functional integrity of the entire retina. Pattern ERG is predominantly from the posterior pole. In multifocal ERG, as the name suggests, we check multiple points on the posterior pole, that is the macula. Right. This is how a typical fulfilled ERG printout looks like. We'll have a dark adapted response, which is recorded after 20 minutes of dark adaptation. So which basically, needless to say, it is predominantly a rod-driven response. Once we increase the stimulus intensity, there will be some contribution from cones also. So then we lighted up the patient for 10 minutes. In that, if you stimulate the retina with 3 candela per centimeter square, what we get is a predominant cone-driven response. In the same light adapted state, if you stimulate the retina with 30 Hz flickering light, what we get is an the exclusive cone-driven response. So basically, we started with an isolated rod-driven response, and we ended with an isolated cone-driven response. So whenever we look into the ERG, we need to look whether the cone component is affected, or rod component is affected, or both are affected, or if there are any special waveforms. So let's try to jump into some of the case examples. So these are, as I keep telling, these are stories of different individuals. So this is one such story of 41-year-old gentleman who presented with, eye strain, burning sensation, light sensitivity, and I was diagnosed to have dry eyes and also, started treatment for keratoconus elsewhere. But symptoms persisted, it got never relieved, and he developed work-life stress, altered sleep cycle. So he changed workplace, switched jobs due to bright light. Finally, he had to consult a psychiatrist where he was started on amitriptyline 10 mg and also propranolol for anxiety. He had an associate hypothyroidism and hyperlipidemia. So obviously, because of all this stress, he became alcoholic and also smoker. So when he came to us, so we evaluated, there was no history of consanguinity or any other family members having any retinal issues. Basically, it was referred from refractive department because they clearly told there is no keratoconus or any dry eyes. Just you guys have a look at it if there is any retinal issue. So this was his vision and anti-segment examination profile. Vision was perfectly fine. So 6/6 sensitive, the color vision is also fine. So rest of the anti-segment examination was normal. So fundus examination, again, was absolutely normal. So this is the bilateral wide field of autofluorescence image, which is again normal. So for the sake of completion, we did everything. So the OCT that we did, which definitely appeared normal, but for me, in the right eye, in the subfoveolar zone, the interdigitation somehow it appeared little attenuated. So if somebody says it's normal, it could be normal, but for me, it looked little suspicious. So for the sake of completion, we did OCT angiogram, also the field test, which was normal, both 30-2 and 10-2. Then finally, I had to do an ERG just to be very sure that we are not missing. If you carefully observe this ERG, the bottom row represents the normal, and the top two rows represent the recordings from right and the left eye. In this, the dark adapted responses are completely normal. If you look at the light adapted responses, there is 50% reduction in amplitude compared to the normal. So that means this patient definitely has something for which he's having this photophobia like symptoms. That means he's not lying. This is not malingering. Okay. So far, he has been, visiting so many hospitals where he was told like everything is fine, everything is fine. First time we got an evidence that there is something wrong in the retina. So we went ahead and did multifocal ERG. Again, there was a reduction in central response. It was more in right eye compared to the left eye. So the pattern ERG was also telling the same story. The right eye seems to have affected more. Left eye was almost near. So now if you put everything together, the OCT change which is suspected and the corresponding light adapted response, the multifocal ERG, pattern ERG, everything fits in. So this is what basically, this is one scenario where we didn't give any treatment. We just told him that there is an explanation for your symptoms, and patient was so happy. I just gave him photochromatic glasses and also gave a letter to the workplace, stating that he has some issues with the cone system because of which he is uncomfortable with the bright light and all that. So he's been following with us for more than 2 years and is perfectly all right. He's already off all antipsychotic medications and is leading a normal life. Okay. So, and we went ahead and wanted to understand, we know the problem. No? What could be this? It could be anything. It could be atrophic macular dystrophy. It could be a variant of bone dysfunction. We also did a genetic testing. At this point of time, we are not able to pick any, mutation which will cause this, which can happen if there is any, very rare bone dysfunction syndrome. The present genetic testing system may not be efficient enough to pick those. We are keeping him under follow-up. We maybe will repeat the test after 2 years. Coming to the second case example, this was a story of 17-year-old female who complained of deviation of eyes and safety eyes with photophobia. It was noticed since birth, and she was using glasses regularly. She had a high-frequency low amplitude pendular nystagmus, which used to dampen on convergence. So this was a refraction. So the DCV in right eye was 660, left eye was 6 by 48. So the vision was quite okay, but it was close to space. But if you look at the color vision, she was not able to identify, not even the demo plate on Ishiara. So the color vision was grossly abnormal. The fundus clinically looked normal. The OCT was also normal. For white field autofluorescence was also unremarkable. So this was the posterior pole autofluorescence, which was again normal. So, but if you look at the ERG, as compared to the normal, the dark adapted responses, there is a cross reduction in B wave amplitude. And if you look at the combined response, that's something interesting is happening here. The A wave is forming here. The B wave is not even reaching the baseline. It's getting terminated here itself. So this is what we call it as classic electronegative ERG. This is seen in any conditions where there is an inner retinal dysfunction. And similarly, if you look at the photopic responses, so there is almost like 90 to 100% reduction as compared to the normative. So this is a very rare combination where you had features of both congenital stationary night blindness and also an achromatopsia, which is a cone dystrophy. So which is very important to understand. If not for ERG, would have missed this because structurally everything appeared normal. Fundus was normal, OCT was normal, and these patients have a very peculiar profile. So once they go to the dark places, they take extra time to get adapted. Once they go to the very lit places, they cannot tolerate the light. So we need to counsel them and then, suggest lifestyle modification accordingly so that their quality of life can improve. Fine. So next, coming to the next set of disorder, the bestrophinopathy, because I commonly, a lot of reference for these patients which get commonly misdiagnosed for some of the uveitic NCTs are achycoral spectrum disorders. That's why I thought of giving example of these bestrophin related disorders. So the first family was in the family A. The proband was 11-year-old male born out of a consanguineous marriage. He had a vision of 6 by 9. If you look at the fundus, there's a vitaliform deposit right over the macula, which can be appreciated better when we do an autofluorescence test. In the OCT, there's a corresponding subretinal fluid with subretinal vitaliform deposit. So when we did an ERG, it was completely normal. So if you look at the EOG, which is electrooculogram, so the light peak which was supposed to be present here like this, which was absent. So a normal ERG with an abnormal EOG, which is characteristic of a dominant breast disease. Okay. Now coming to the second family. So this was proband was a 25-year-old male. So vision was 6/9. So we had visited multiple, hospital. Finally, was diagnosed as some posterior uveitis, had taken all kinds of immunosuppressants, antivirus, and all those things. But if you look carefully, so the vitaliform deposit, which was limited just to the macula in the first case. So here, if you see, the vitaliform deposit is quite extensive for the fingers. So if you in the OCT, there were both subretinal and also intraretinal fluid. So FFA showed non-specific leakage and staining pattern. In the ERG, the EOG is grossly abnormal, but ERG was also abnormal. So this happens in case of recessive bestrophinopathy. I'll come to it later. So the third family had multiple affected family members, though the proband was a 21-year-old female. So this is the the color fundus photograph, the corresponding autofluorescence and OCT or flow band. The first sibling, the second sibling, and the third sibling, all of them had more or less similar pattern. The vitaliform deposit pattern, fell somewhere between the dominant and the excessive disease. So why there is so much of difference, all in all this family? So the reason being, the first one is a dominant test due to heterozygous mutation in dystrophin gene. So the latter two are recessive test. Again, there is a difference. In the, one is homozygous mutation in dystrophin gene. The second one is a compound heterozygous mutation. That means the mutation at two different locations. So this is an example for, typical example for how, the gene could be same, the inheritance pattern could be same, but the clinical manifestation could be little different. Okay. Unless we know this, we may miss this and we may mistakenly treat this disorder for something else. So to conclude, I would like to show all these three images. If you just observe in the first image, there is some mild fasciitic changes. It is more in the second one, and third has a subretinal fluid. These looks like maybe spectrum of pachychoroid disorder, but it's not. The first case, when we stimulated the retina for long and medium wavelength tone, it was undetectable. When we tested for short wavelength tone, there was an exaggerated response. So this was a case of enhanced response syndrome due to mutation in NR2E gene. The second case is a case of juvenile retinoschisis, which had a typical electronegative ERG due to inner retinal dysfunction. The third case is one of the cases which I just showed in the example. This is a recessive base due to homozygous BEST mutation. So that's why once you put everything in the context, the things become very clear. You should not take any investigation in isolation. I would like to end by what my mentor taught me in more fields. Do not fit electrophysiology into clinical diagnosis, fit clinical diagnosis into electrophysiology. Thank you so much.
Thank you, Dr. Punachandra. It was excellent. And it is always a learning experience. The way you present your slides on complex subjects such as ERG, it's always a learning experience.
Yes, truly. So next speaker, there are so many people who want to discuss, but we will take discussion after fishbowl.
Sure, ma'am. Sure. So I would like to call our last speaker, Dr. Pratyusha. Dr. Pratyusha, who will be talking upon FFA.
Good evening to everyone. Let me just share my screen. Are my slides visible?
Yes, they are, Dr. Pratyusha.
Okay. At the outset, I'd like to thank Jharkhand Ophthalmic Society and Dr. Bharti ma'am for giving me this opportunity. So the topic that's been allotted to me today is fundus fluorescein angiography, the basic principles and interpretation. So I believe majority of the audience here is postgraduate students. So I think I would just stick on to the basics of fluorescein angiography and how we will interpret fluorescein angiogram. So all of you must have seen a fluorescein angiography being performed in your institute, right? So I will not go into the details of how a fluorescein angiogram is done and the theoretical aspects behind it. So we all know that sodium fluorescein is a molecule that basically responds to light energy between 465 to 490 nanometers and fluoresces at a wavelength of 520 to 530 nanometers. So basically, we are sending blue light, which goes through through the blue excitation filter, strikes the retina, and as the sodium fluorescein dye circulates in the retinal and the choroidal circulation, this dye gets excited and then emits a wavelength of light in the yellow-green spectrum, and this is caught by the detector. So when we do a normal first we should understand what is a normal fluorescein angiogram before we go into abnormal fluorescein angiograms. So I'll just show you the various phases in which the dye circulates in the retinal and the choroidal circulation. So after you inject the dye, after about 10 to 12 seconds, you can see this kind of a picture, which is basically what we call as the choroidal flush. This is nothing but filling up of the choroidal vessels. The long ribbon-like structures that you're seeing here are the choroidal vessels. The dye gets into the lobules, the choriocapillaries, which are arranged in lobules, and it creates this choroidal flush. You might be also noticing this retinal vessel getting highlighted here. This is the cilioretinal artery, which also fills up with the choroidal circulation because its origin is from the ciliary arteries. So the dye first reaches the ciliary arteries and then it reaches the central retinal artery. So after about a couple of seconds after the choroidal flush, we see something like this, where the dye starts entering into the retinal artery. And this is the arterial phase of the angiogram. The blood flows through the arteries, through the precapillary arterioles, into the capillaries, and then it goes through the precapillary venules into the veins. So once the veins start filling up, we see this arteriovenous phase, wherein the dye is actually concentrating on the walls of the veins. So this is something called as a laminar flow of the dye in the veins. And this, when you see a picture like this, you're reading a angiogram in the arteriovenous phase. And then we have the next phase. That is, here you can see that the veins are now completely filled and the concentration of the dye in the arteries and the veins is almost equal now. So this is the early venous phase. And then the dye slowly starts washing out of the arterial system, and it starts, and the veins start becoming appearing brighter. So this is the late venous phase, which normally is about 10 seconds after the arterial filling. And then as the angiogram proceeds, we have the recirculation phase and the late phases, wherein slowly the dye is getting washed off both from the retinal and the choroidal circulations. But what you need to observe is this staining of the optic nerve head, which happens as we reach the later phases of the angiogram. So if you are asked to read an angiogram and you need to understand which phase it is, kindly look at the disc staining. This disc staining happens in the later phases of the angiogram. So this is an even later phase where you can see prominent disc staining with almost no dye in the blood vessels. So I'd like to draw your attention to this particular structure. This is the foveal avascular zone. So when you look at a fluorescein angiogram, you can see this kind of a cobweb-like appearance around the fovea, which is the foveal avascular zone. Now this has to be intact. The size has to be less than normally about 400 microns. So it has to be of the adequate size, and the margins or the continuity of this retinal capillaries, perifoveal capillaries, has to be maintained. And then we call it as a healthy foveal avascular zone. So this becomes very important when you're dealing with cases of macular ischemia where the foveal avascular zone may be disrupted. So, now today with the advent of OCT and OCTA, which Dr. Subneshwari ma'am very nicely presented, the indications to do fluorescein angiography, the dye-based fluorescein angiography, has drastically reduced, but it still has its role for two reasons. One thing is, of course, as madam said, the leakage component cannot be made out in OCTA, which you can make out in fluorescein angiography. And more importantly, OCTA is a luxury and it is available only in certain institutions, probably in the top 10% of the institutions that are available in our country. And, most of us, if you're retina practitioners outside, we still have a fluorescein angiography, an invasive fluorescein angiography, because the investment for Opta is quite high. So when we interpret an fluorescein angiogram, we normally use these terminologies. One is hypofluorescence, and the second one is hyperfluorescence. So hypofluorescence is of two types: filling defect and block fluorescence. Hyperfluorescence is autofluorescence, pseudofluorescence, transmission defects, leakage, pooling, and staining. So let's see all these with examples. So this is a patient who had a massive retinal hemorrhage. There are various levels of hemorrhages here. If you see, there's a subhyaloid hemorrhage, there is a subretinal hemorrhage, and there are intraretinal hemorrhages. So when you look at the corresponding fluorescein angiogram, you can see that this whole area is dark, which is hypofluorescence. But this is a kind of hypofluorescence basically because something is blocking the fluorescence from reaching the detector. So this is called as the blocked fluorescence. So this is blocked retinal. This hemorrhage is blocking the retinal and the choroidal fluorescence in this angiogram. So we have another example here. There is hypertrophic retinal pigment epithelium, and when we do an angiogram in this condition, you can see that the retinal circulation is well seen, whereas the choroidal circulation is masked or it is blocked. So this is blockage of choroidal fluorescence due to a hypertrophic retinal pigment epithelium. The next type of hypofluorescence, as I said, is the capillary non-perfusion. Capillary non-perfusion, as the term indicates, it means that the blood is reaching the arterioles, but it is not getting into the capillaries because the capillaries are blocked. So various vascular conditions like vein occlusion, stablic retinopathy, retinopathy of prematurity, all of them ultimately manifest as capillary non-perfusion areas. And when you look at these areas, which are normally supposed to be perfused, you're seeing no signal. I mean, you're not seeing any fluorescence over here. So that is why we call it as capillary non-perfusion. Another example here, it's a branch retinal vein occlusion. So if you see the normal, between the arterioles, you should have this kind of a, is my pointer visible? Dr.
Yes,
Rahul,
ma'am.
is my
Yes, ma'am. Yes, ma'am.
yeah,
It's
yeah,
visible.
Yes,
yeah.
yes, it is visible
So,
and it is very interesting.
thank you, ma'am. Thank you. So, if you see this kind of between the vessels, the arterioles, or the you should see this kind of fluorescence normally. But if you look at this portion where there is a branched retinal vein occlusion, you can see that there is no perfusion here. So, these are called as capillary non-perfusion areas. Okay. So now we move on to hyperfluorescence in a fluorescein angiogram. So, if you look at this picture, you can see that the optic nerve head is actually hyperfluorescent. So this is because it is having optic nerve head drusen. Now, these drusen actually don't require sodium fluorescein to emit fluorescence. So you just take a a pre-injection photograph, and you will realize that the fluorescence is already present. So this is called as autofluorescence. And some of the lesions which are known to cause autofluorescence are we have optic disc drusen, astrocytoma, and so on. The actual hyperfluorescence that we are talking about now is hyperfluorescence due to transmission defect. So what is transmission defect? Now, if you look at the color fundus picture over here, you can see multiple areas of retinal pigment epithelial atrophy. And this is a patient basically with dry AMD. So if you see the angiogram, if you follow the angiogram of this patient, you will see that the hyperfluorescence is increasing. The brightness is increasing and decreasing with the choroidal fluorescence. That is, as the choroidal fluorescence is increasing, the angiogram is appearing hyperfluorescent, and then it is decreasing. So it is basically nothing but transmitting the choroidal fluorescence through the defects in the retinal pigment epithelium. This is a diabetic retinopathy patient. You can see multiple microaneurysms, cottonwool spots, rod blot hemorrhages, and so on. So if you look at this angiogram, you'll see these multiple hyperfluorescent lesions, which are nothing but the microaneurysms in the early phases. And if you see the later phases, you can see that that distinction as individual white spots is gone, and now it's become sort of a smudge, although you still can make out some microaneurysms. A lot of these microaneurysms have become a kind of a blur with a smudge. This is because the dye is leaking out of these microaneurysms into the retinal tissue, and this is what we call as leakage. So there's another type of leakage that happens in central serous retinopathy. I will come to that a little while later. Then there is what is called as pooling. So what is pooling? Pooling is basically accumulation of the sodium fluorescein dye into a confined space. For example, a serous PED, a pigment epithelial detachment, or it could be into the subretinal space, as we see in central serous retinopathy. So there is a leak here, and that is going and filling a cavity, and that cavity is what we call is what we are seeing as pooling. The third type of hyperfluorescence is staining. So in staining, there is some abnormal tissue which is actually capturing that sodium fluorescein, retaining that sodium fluorescein throughout the angiogram. And so what is happening is this intensity of the dye is increasing as the angiogram proceeds. But the size of that, that lesion is remaining the same. So this is a disciform scar in wet AMD. You can see that the dye is progressively accumulating in this abnormal tissue. That is, it is getting stained. Okay. So as I said, the indications have drastically reduced, but still it has a role. So in diabetic retinopathy, one of the commonest things I think all of us will see in our retina practice, what is the role of FFA in the current scenario? Of course, it is to identify macular ischemia. You're giving anti-VEGF injections, macular edema is reducing, but the patient's vision is not improving. So that's the time when you want to think and, you want to really look for macular ischemia. And that's where fluorescein angiography will really help. The second thing is when you're trying to distinguish intraretinal microvascular abnormality from a new vessel. Okay, so I'll show you an example. So for example, if you see here, this is a patient who had a little bit of a cataract. We could see that definitely severe NPDR findings are there in the fundus, but we really could not pick up a new vessel in this patient because of the thick cortical cataract. So we went ahead and did a fluorescein angiogram. You can see these areas, again, capillary non-perfusion. Pay attention to these kind of vessels which are there between the arterioles and the venules. These are the intraretinal microvascular abnormalities or some kind of abnormal vasculature in diabetic eyes. So this was something that was seen throughout the fundus. Of course, the microaneurysm related leaks are there everywhere. But do you see this portion? This portion, there is an intense leakage that is happening. This is a new vessel. So this kind of a leak which happens only in new vessels. It doesn't happen in intraretinal microvascular abnormalities or IRMA. So this is where fluorescein angiography plays a very, very important role. Okay. So in vein occlusions, again, the indications are almost the same. That is, if you want to look for macular perfusion and if you want to distinguish collaterals from new vessels. I'm sure a lot of people, a lot of you would have seen these kind of vessels on the disc, and you're always confused. Wait, am I dealing with neovascularization of the disc, or are these optociliary shunt vessels? So optociliary shunt vessels commonly be seen in central retinal vein occlusion. So when you have a doubt, now these are very typical cases, so we can probably even with clinical examination you'll be able to make out, but sometimes the differentiation becomes a little ambiguous. So when you do a fluorescein angiography, you can see that an NVD leaks profusely, whereas optociliary shunt vessels don't leak. So this is where in vein occlusions, the angiograms can be useful. Then, of course, in retinal artery occlusion, it's mostly a clinical diagnosis, but sometimes rarely we might need to do retinal fluorescein angiography. So if you look at this picture, this is a classic cherry red spot, what we describe for central retinal artery occlusion. And if you look at the angiogram here, even after 33 seconds of starting the angiogram or injection of the dye, the dye has not reached the arterial circulation. So this is what we call as a delay in the arm retinal time, right? So as I said, CSR again. So there are two kinds of hyperfluorescence that are happening here. One is a leak. Now this leak is going to collect, this dye is going to collect in this pool of subretinal fluid, and that so there is both a leakage as well as a pooling which is happening in this particular condition. So this is the classic smokestack appearance, what we all read in our textbooks. There is another kind of leak that happens in CSR. This is again subretinal fluid in this region, angiogram showing a small hyperfluorescent dot, which as the angiogram progresses is enlarging in size and intensity. And this we call as an ink blot leak. So of course, in dry AMD, we don't need to do a fluorescein angiogram, but I'm just showing you how it would look if you would do it. So these are drusen, which are showing staining, whereas this is RP atrophy, which is showing window defects. So you can see in the same dry ARMD, you can have different patterns when you do a fluorescein angiogram. So again, for choroidal neovascular membranes, we no longer need to do fluorescein angiography in every case, but this was during those the occult CNVM. So classic CNVM classically described as a lazy pattern of hyperfluence which leaks in the phases. So this black thing. So you might ask, what is this black thing? It's difficult for me to tell, what is this black shadow over here? So always remember, interpret a fluorescein angiogram of beginning to leak from, and we have fibrovascular PD, there is pigment epithelial detachments. The other place where FFA really helps is in distinguishing BKH from a multifocal CS, them present with multiple pockets of subretinal fluid, and you don't know what you're dealing with because one needs to be treated with corticosteroids. In that case, you have to completely avoid corticosteroids. So that's where you do an angiogram and you will see these multiple pinpoint leaks at the level of the RPE, and very importantly, this disc leak, which is characteristic of Vogt-Koyanagi-Heda syndrome. And in certain choroiditis, it helps you assess the activity of the choroiditis. For example, this is a patient with right eye active choroiditis and left eye an inactive scar. So the scar basically only accumulates the dye, that is basically it gets stained. Whereas, this is a patient with, you can see this edge which is having this kind of a leakage or some smudge going on here. So this indicates that the edge of this lesion is still active. So these are just a few examples of where we use fluorescein angiography in the real world. There are a lot of advances in fluorescein angiography because it's more than 70 years old now. We have wide field and ultra wide field angiography where almost up to 200 degrees of the retina can be captured in a single frame. We have video fluorescein angiography and also RedCam FFA. RedCam is especially useful in babies with retinopathy of prematurity. So with that, I come to an end. Thank you all for your patient hearing.
Thank you, ma'am. Thank you, ma'am.
So please stay with us because thank you so much. And actually, I realized this gravity of this session because for 20 years, I was practicing medical retina in my hospital doing barrage laser, FFA, OCT, PRP. So I understand. And I realize, and I think the PGs, they will all come again for discussion, and the junior young retina specialists have also joined. Dr. Ritika, Dr. Archana, Dr. Divya. So let us start first PG fishbowl session. So I'm going to start the PG fishbowl session. So this is getting organized for the first time by Jharkhand Ophthalmological Society, and today is our episode 1. This is the brainchild of Dr. Shweta Walia, Chairperson Scientific Committee, Madhya Pradesh, and she agreed for being moderator of this session. The fishbowl training method is a structured collaborative learning technique where a small group inner circle discusses a topic, and while a larger group, that is the outer circle, observes and takes notes. It enables in-depth discussion, models active listening, and allows for large group participation without chaos. It is effective for complex subjects, debates, and skill building. And you all expert panelists know, because you all have been participating as expert panel. So we have with us Dr. Sunil Kumar, our JHOS ARC chairman, Dr. Rahul Prasad, Dr. Joint Secretary, Jharkhand Ophthalmological Society, Dr. BP Kashyap, the past president, Jharkhand Ophthalmological Society. Now over to Dr. Sunil to introduce the mastermind of this fishbowl, that is Dr. Shweta Walia. Over to Dr. Sunil.
Yeah, good evening to all. Yeah. So I welcome all in this fishbowl session. Introduce the moderators of today's session, Dr. Sweta Walia. So will you show the slide, introductory slide?
Yes, yes. Is it visible?
No, not yet.
I don't know what has happened.
Yeah. Now it is visible. Yeah. So Dr. Sweta Walia is a professor, MGM Medical College, Indore, and she is also the chairperson, Scientific Committee, MP State Ophthalmological Society, and she is the chairperson, Scientific Committee, OS, Central Zone Representative, OTSI, Central Zone Representative, IS, International Society of MICS, and she has more than 50 publications in national and international journals, and she has received so many awards, and she has innovated techniques of the sutureless, glueless SFI in 2016. So I welcome Dr. Sweta Valyaman for moderating the session of this fishbowl. And another moderator is Dr. Bharti Kashyap. We all know she needs no introduction.
Yes.
And we also have the expert panel for the today's fishbowl session. Dr. Suvina Naran, she is the professor of ophthalmology at GMCH Chandigarh. Dr. Suga Neswari, she is the senior VR surgeon from Sankar Nethralaya, Chennai. We have with us Dr. Purna Chandra, consultant VR surgeon, Narayana Nethralaya, Bangalore. And Dr. Pratyusha Ganesh is the additional professor at AIMS Mangalagiri. So today we will have the two case presentation. The first presentation will be by Dr. Pragya Chauhan. She is the DNBS student, second year from the Kashyap Memorial Eye Hospital. And the second presentation will be by Dr. Irsad Khan. He is second year DNBS student from the Kashyap Memorial Hospital, Ranchi. So thank you.
So over to Dr. Rahul Prasad for just a one-liner introduction of the inner circle and the outer circle.
Yes, ma'am. So for our ma'am, for our inner circle participants, we have postgraduates from MGM Jamshedpur. We have postgraduates from TMH Jamshedpur, from Bhagwan Mahavir.
Please
from
name
Hospital.
them.
Yes, ma'am. Yes, ma'am. So from MGM Jamshedpur, we have got Dr. Amar Kumar, Dr. Mayank Naran, Dr. Vikas Thakur, Dr. Neha Chaudhary, and Dr. Nidhi Sharma. From TMH Jamshedpur, we have got Dr. Bhavya Chaudhary, Dr. Raksha Kumari, Dr. Richa Kumari, and Dr. Sana Afri. Then from Bhagwan Mahavir Manipal Hospital, Ranchi, we have got Pooja Tanwar and Dr. Shreya Kaul. From Gandhinagar Hospital, CCL, we have got Dr. Lalita Priyaji. And from Bokaro General Hospital, we have got Dr. Nupur Gupta and Dr. Dushar Dhiman. That comprises the inner circle. For the outer circle, we have our own residents, Dr. Anamika and Dr. Vatsala. From Bokaro General Hospital, we have got Dr. Anamika Thakur and Dr. Ujwal. From Gandhinagar, Dr. Gagandeep Singh Gulati from Kashyap Eye Hospital and Dr. Shubhan Singh from Kashyap Eye Memorial Hospital, Ranchi.
So thank you, Dr. Rahul, for introducing all the PGs from inner circle and outer circle. And today, maximum postgraduate students have joined. So before we invite Dr. Pragya Chauhan and Dr. Ishad Khan, I invite Dr. Shweta Walia for a brief introduction of the session from the mentor itself who has created it. So over to Dr. Shweta Walia before the starting of the presentation by Dr. Pragya and Dr. Ishad. Dr. Shweta,
Thank you, Dr. Bharti, for your kind words and adopting the technique that we were doing in MP state for past 2 years in Jharkhand. And we found that it is actually beneficial for the residents because they take part in active discussion. And also the listening skill of residents is improved by listening to the what others are saying. So the concept over here, Dr. Bharti has already told that it is basically for learning, where one presenter is there, will present a case. In this scenario, she'll be presenting case for 6 minutes. The residents of inner and outer circle will be actively listening to the case presentation. Then first turn will be that of inner circle, and they will discuss the topic, ask question from the presenter. And after all the participants of inner circle have asked question from the presenter, then it is the turn of outer circle. They will ask question if any particular thing is left behind, and they can also add their queries if they have any. And finally, after outer circle, it is a turn of our experts to give their final comments, or if they want to ask some question from the resident, from presenter, they can ask. So our experts, Dr. Subina Narang, Dr. Subneshwari, and Dr. Patyusha, they are all well versed with this
and Dr.
technique.
Purna.
So that is actually the three are already participating for past 3 years and have been experts in MP state programs. And Dr. Purna, I think it will be.
You think?
You'll also like this concept, and definitely you will add to this program, and we'll have a great learning from you as we had from your presentation on ERG EOG. So hope that everyone will enjoy this session, and it's
And
my
please
request.
announce the cash prize.
Okay,
For
ma'am,
the
that you will announce the cash
No,
prize.
no, you have to select.
So I will not select. The experts will come up with the consensus for the best question from inner circle and one best question from the outer circle. So it is my request for the experts to take note who has asked the best question and come up with a consensus and announce the best question from inner circle and from the outer circle. And Dr. Bharti will announce the cash prize, what she is going to give to the residents.
We have kept, yes.
So I would also request all the residents to switch on their videos, and better if you can put your name so that we know who is asking the question for better interaction.
All residents, please.
So okay, all of you can switch off.
And please camera on.
So while Dr. Pragya will be presenting, you carefully listen to what she is presenting and be prepared with your questions, and the experts will announce the best question from inner and outer circle. So may I request Dr. Pragya to start sharing your screen?
Yes.
And yes, please. So you can make it slideshow.
Pragya, make a slideshow.
Right. So please start your presentation.
Good evening, everyone. This is Dr. Pragya Chauhan, a second-year resident from Kashyap Memorial Eye Hospital. I'm going to present a case of a 22-year-old unmarried male who presented to our OPD with diminution of vision, which was right in both eyes, but right eye more than left eye, and it was since childhood. The diminution of vision was gradual, painless, and progressive in nature, associated with nyctalopia. There was no history of pain, redness, floaters, or flashes of light. Also, there was no history of any other ocular trauma. No history of deafness was also present. Past history was not significant. Also, the family history was not significant. Although we could not get a proper pedigree, but the history the patient gave, according to that, I have generated this pedigree. He was the first one to be affected in the family. On general examination, patient was alert, conscious, and cooperative. Facies were normal, pallor, cyanosis, icterus, clubbing, edema was absent. In short, systemic examination was generally normal. On slit lamp examination, size of the pupil was 3 mm, circular in size, central. Reactions were present, both direct and consensual. RAPD was present in right eye, but it was absent in left eye. On applanation tonometry, IOP was 12 mm HG in right eye and 14 in left eye. Visual acuity was hand movement close to face in right eye and 6/36 in left eye. Near vision could not be assessed and it was N/10 in left eye. Color vision could not be assessed in right eye, but it was affected in left eye. Ocular movements were full, free, and painless in all directions of gaze. Position of the eyeball and size of the eyeball was normal. Slit lamp examination, conjunctiva, cornea, lens, interior chamber, everything was normal in size, normal. We could not find any positive findings in the interior on the slit lamp examination. On posterior segment examination, media, there were no vitreous degeneration seen while doing indirect ophthalmoscopy. Size and shape of the disc were normal. A slight temporal pallor was noted in both the eyes, but margins were well delineated. Bony spicules were present around the macula and juxtamacular area. A mild arteriolar attenuation was also present. Investigations we did were ultra-wide fundus photo, OCT macula, and multifocal ERG. This is the ultra-wide fundus photo showing bony spicules which were more prominent in the macula and the juxtamacular and juxtapapillary area with a slight temporal disc pallor. This is the fundus photo. This is the OCT image showing symmetrical retinal thinning and photoreceptor layer disruption. We also tried to do multifocal ERG. Both eyes shows noisy waveforms and it was unreliable since the vision of the patient was very low. My provisional diagnosis for this case was asymmetrical inverse retinitis pigmentosa. Differentials could be choroidal dystrophy, cone dystrophy, post-inflammatory sequelae, retinitis punctata albicans. Summary. This is a case of a 22-year-old male who presented with DOV, right eye more than left eye, since childhood, with no systemic illness and no similar complaint in the family. On examination, BCVS was hand movement in right eye and 6/18 in left eye. Normal interior segment. On fundoscopy, both eyes showed bony spicules involving macula, juxtapapillary area, with slight temporal disc pallor and mild attenuation. Retinitis pigmentosa typically presents with night blindness and peripheral vision loss. But this is a case of inverse retinitis pigmentosa, which can affect central vision at an early stage. As of now, there are no treatment modalities available. Multiple research and advancements are underway. Currently, no treatment modalities. Photochromatic glasses can be given to the patient or trial of low vision aids can be given to the, but the most important is we should go for genetic test followed by genetic count. Recent advancements were gene therapy, prima, stem cell therapy, and CRISPR gene editing is also being tried. They are not like implemented anywhere. Thank you.
Thank you, Dr. Pragya, for such a wonderful presentation. And now the case is open for discussion. Hope the inner circle is ready. So who is going to start the discussion? Dr. Amar, can we have the question from your side?
Yes, ma'am. Good evening, everyone. My question is, what is the differentiate between ma'am said that there is a
your voice is not clear.
Voice is breaking.
Hello. Am I audible? Muffled. Hello, am I
Better.
audible?
Yes, you are better than earlier. Please be loud.
Ma'am, good evening, everyone. My question is about how to differentiate that the features shown in inverse retinitis pigmentosa and rod cone dystrophy. How to differentiate between these two?
How to differentiate inverse retinitis pigmentosa from?
Cone dystrophy.
From rod cone
Rod
dystrophy.
cone dystrophy.
From root cone dystrophy. See, there are many things. First of all, we can go for multifocal ERG. We can go for in cone dystrophy. Mainly the multifocal ERG we can go for.
Yes.
Yes, Dr. Amar, are you satisfied with the answer, or would you like to add to it or ask something else?
No, ma'am.
Okay. So you answered very well, Dr. Pragya. So from whom are we going to have the second question? Bhavya, Dr. Pooja, Dr. Lalita, who is going to ask?
I have a question.
Yes, please.
Good evening, everyone. Good evening,
Dr.
everyone.
Yes.
Yes, ma'am. Introduce yourself. My name is Dr. Shreya. I'm a second year DNB resident at Manipal, Ranchi. Dr. Pragya, my question is, how did it come up to you? Like, why is your first provisional like towards inherited disease? What acquired causes did you think of first? And like, for example, you very early on mentioned about the pedigree chart that you showed, like you tried to attempt drawing a pedigree chart. So what made you think more towards inherited? For example, as basic as vitamin A deficiency, was that on your mind first?
Vitamin A deficiency, mainly it is not that progressive. But the patient said that vision was progressively diminishing. And moreover, the fundus photos and the optus we show it, the kind of fundus photo we show it is more often a hereditary type of dystrophy. We are like supposedly some dystrophy is there. That is why we are pointing towards genetics thing.
Yeah.
So very good question, Dr. Shreya. Yes, you want to ask something else? Please go ahead.
Yes, ma'am. That is in a general question. As a PG, I have that curiosity. Like, since this case is being described as an atypical RP, but as they have mentioned in the case, we see two signs out of the three of the triad. So we have seen in this case, as Dr. Pragya mentioned, bony spicules were there, attenuation was also there, and slight temporal pallor also they've mentioned. So at what point do we actually call it atypical RP?
Because typical RP involves periphery first. It involves first periphery and then it involves center. But this is involving first the center, close to the macular area. That is why we are calling it atypical.
So on the basis of the pattern of diminution of the damage you have actually clinically you have noticed that.
So very good, Dr. Pragya. So from whom are we going to have the next question? Can we have it from Dr. Pooja, Dr. Lalita, Dr. Mayank? Anyone from inner circle? So I think you can stop sharing your screen so that we can have all the participants on the screen. Yes, please. Dr. Lalita, would you like to ask something? You can unmute yourself and ask, please.
So already Gandhinagar has asked.
Yes, she has to ask. Dr. Lalita, please proceed. Please. You are not audible. I think you are muted or you are not connected.
So one question should be asked from CCL, one from Bokaro, one from TMH.
So we can do that. We can do that, definitely.
Yes. One from Kashyap.
Ma'am, good evening, everyone.
Yes.
Dr. Priya, first year diploma ophthalmology from CCA Hospital.
Yes.
Ma'am, I just wanted to know the difference between the full field ERG and multifocal ERG, ma'am. Since I'm beginner, I just
Okay. Multifocal ERG mainly involves the center 30 to 40 degree. We are just observing the central part, macular part. Central 20 to 30 degree we are checking. Okay. And in full field ERG, we are checking for the whole retina. Since we have a disease in which the mainly macula and area close to macula was involved, so we did multifocal ERG. But when in case of retinitis pigmentosa, it is a case of periphery. In that case, we would like to do full field ERG.
Okay, ma'am. So even if we do multi-field ERG, will it be very helpful in RP, ma'am?
Multi-field, are you trying to say
Multifocal ERG.
multifocal, it is good for atypical. Whenever any disease involving macula is there, then we will try to do multifocal.
Okay, ma'am.
Anything related to central 30 to 40 degree, then multifocal is preferred.
Like Usher's syndrome, kind of syndromes, multifocal will be.
But I mentioned that in Usher there is like sensory neural hearing loss was also there. So that is why I firstly said it was not there.
Okay. Thank you so much, ma'am.
Very good question, Dr. Lalita. Yes, Dr. Pooja, you wanted to ask something? Dr. Pooja Tanwar, yes.
Good evening, everyone. My name is Dr. Pooja Tawar, DNB first year from Manipal Hospital. It's just a curiosity from my side. I was just asking, as the typical RP and atypical RP, both are the inherited. And as ma'am said, Dr. Pragya ma'am said that there is a no permanent treatment for both of the like typical and atypical. So like, how I can say that what was the main purpose of differentiating that it is the typical or atypical? Is it only because of the involvement on the clinical basis, or like there is something that they are differentiating on the basis of the treatment also?
See, mainly typical RP, there is many a times mutations were present. This is a case of sporadic thing. First time the patient came to us without any genetic involvement. In typical RP, usually the mutation in rhodopsin gene. So we can try for that. We can do the genetic testing. If there is a rhodopsin gene mutation, we can go for treatment according to that.
Okay. So, it's like basically I'm trying to say, asking that, okay, like a treatment modality is also different for typical and atypical.
But I'm not completely, but yes, of course, if typical RP is because of a genetic mutation, so of course treatment will differ according to.
Thank you.
Thank you,
I
Dr.
think we should ask the outer circle now. What do you say?
So we have two more over here, Dr. Nupur and Dr. Nidhi. Would you like to ask something, Dr. Nupur? From inner circle, we can move on to outer circle.
See, I am asking whether one person from Bokaro has asked or no. One person from Bokaro should ask. One person from TMH, they have asked, I think.
From TMH, they have asked. So, if ma'am. Yes, please. Yes. What's your name? Please introduce yourself.
Ma'am, I'm Dr. Neha Chaudhary from MGM. Jamshedpur. Ma'am, I want to ask how to differentiate like Stargardt's from inverse retinitis pigmentosa, as in both case central scotoma is seen. So how to differentiate that?
Two ways are there to differentiate Stargardt's from RP. First is the fundus. Fundus will be different. In Stargardt's, we will get different kind of a fundus image. We will not get this type of a bony spicules or disc pallor. And second is ERG. Through ERG, we can also differentiate Stargardt's and retinitis.
What findings are that we see in ERG?
Stargardt's is more often a road dystrophy, and my case is more often a cone dystrophy. So in cone, that is the main difference. For Stargardt's, we will go for full field ERG because we are looking for a cone thing, and here we are looking for a for a rod thing. In my case, we are looking for a cone thing.
Okay. So the best part of fishbowl technique is that once your turn comes, then only you can ask the question. So once all the inner circle is complete, we'll move on to the outer circle and then to the experts, and we'll definitely would like to take the input of Dr. Poon Chandra.
Yes.
I just wanted to ask Shweta ma'am one thing. Are you noting down the question, because there are so many wrong questions, so many wrong answers? So later we should.
I'm noting down all the questions.
You can intervene. What do you say? Because there are so many wrong question answer, whatever.
Yes, I'm writing it down.
Thank you so much.
So let's move to the outer circle. Dr. Anamika Chaudhary, who is...
Yes, ma'am.
Yes, please.
Yes,
You're
ma'am.
for your turn. Please ask your question.
Yeah, first of all, Dr. Pragya, it was a very nice case presentation. I would just like to ask that what was the grade of RAPD, as you mentioned that RAPD was present? And secondly, was there any systemic examinations which were conducted on the patients? Because we have seen that in some studies, inverse retinitis pigmentosa has been found to be associated with, first of all, you said sensory neural hearing was not there. Nice, and some also gynec disorders. So the systemic examinations were ruled out, and what was the grade of RAPD and why RAPD was there? So
Systemic examination was ruled out. That is why I mentioned systemic history was normal. Grade of RAPD, I just forgot to mention in the PPT.
it's okay. It's okay. Thank you so much.
So there is another Anamika also over here, Anamika Thakur. Would you like to ask the question or?
Gagandeep.
Yes, Dr.
Shubham.
Gagandeep.
I want to ask, good evening, everyone.
Yes, please. Yes, please.
Myself, Dr. Anamika Thakur from Mokaro General Hospital. My question is that how does multifocal ERG help in monitoring progression?
How does multifocal, you are specific to this case or you are asking in general?
General case. General and specific to this case
In
also.
this case, the multifocal ERG was not reliable because the vision was very low. Multifocal ERG is reliable when vision is more than 6/16. In my case, multifocal ERG was not reliable. So we cannot use this for disease monitoring.
Okay.
Thank you, Dr. Anamika. Dr. Gagandeep, would you like to ask some question?
Not yet, ma'am. No. Thank you.
Gagandeep, Shubham, Neeraj.
Dr. Vatsala, she was active earlier. Please, if you would like.
Good evening, everybody. First of all, Pragya, it was a very great presentation, and also you answered most of the questions in a very nice manner. I just have two basic questions. So, firstly, you said that the pupil size was 3 millimeter. I just wanted to ask, how did you measure the pupil size? Because if you would measure it with a torchlight, the pupil would constrict. So the normal pupil size could not be measured by torchlight. And the second question is dorzolamide of topical dorzolamide is of any use in inverse retinitis pigmentosa?
Ma'am, first of all, I think whenever there is a edema in OCT, then we can go for oral carbonic anhydrase inhibitors, not for the topical ones. And what you're asking about the pupil size, I just wrote in like the normal one. Matlab, it's not like how I measured it somehow.
So basically, there's a pupilometer by which have a small circles. Every circle has a size, so you can compare it with the size.
Yes, ma'am.
Yeah, thank you.
Okay.
So anyone left from outer circle who would like to ask something? Or we move on to the experts because we have also one more presentation to go.
Yes, move to the, I think, to the experts.
Okay. So let's have the inputs of our experts. So who is going to give the input? So Dr. Subina, would you like to give your expert comment? Dr. Sugneshwari?
Yeah, actually, it's a wonderful the way of, the whole thing, how it got conducted was very nice. So I enjoyed the flow of the thing. So most importantly, like to say, like few of the questions which was asked by, certain people, like how do you differentiate? Why do you think in terms of this is an inherited dystrophy, and why not that it could be an infectious etiology? Or could it be any other inflammatory pathology? Those differentiation, that is something really important. But my only thing is, was there an ERG done in this patient?
Sorry, ma'am, why ERG was done?
No. Was an ERG done in this patient? Because I think I missed on that.
Multifocal ERG, ma'am, was done, but it was not.
No, I'm asking about full field ERG.
No, ma'am, full field ERG was not done.
because that is the most important test if we are talking about. One is a full field ERG and another should be a field examination.
Yes,
Was a field. So these two are relevant if you are talking about an inherited retinal diseases.
Okay,
You know, because without that to draw conclusions, and usually if a multifocal ERG has to be done, you cannot do it without a full field ERG. You
Yes,
should have a full field, and then after that only you try to do a multifocal ERG. And another thing also, what was the color vision in your patient? Because the left eye seemed to be having 6/18 vision. So
ma'am,
what
color vision,
color vision?
we did color vision, it was affected.
No, affected means you need to tell what is the how many number of plates, what is the involvement.
Ma'am, it
Because
was
affected, not affected is not the answer. If you are telling about color vision, you need to tell what is the modality that was used for identifying the color vision defect. And if you are using Ishihara, what is the number of plates that has been defective. So all these things you need to kind of tell, because that is most important when you are talking about, you know, inherited retinal diseases. That is predominantly mandatory.
Yes, ma'am.
And yet another point is, if your fundus photograph, if we kind of see, the blood vessels weren't that much attenuated when we see because you had shown one fundus photograph which was showing only the posterior pole, and another one was an optos image. So in an optos image, it is very difficult to probably, you know, sometimes it becomes difficult to talk about the caliber of the blood vessels itself, because it is a wide field image, you know, you really can't make out the caliber. So unless and until you take a posterior pole where you would like to really appreciate the blood vessel caliber. Because if you see your fundus photograph itself, that was not showing an attenuated vessel, and you kind of had more of pigmentation which was on the posterior pole. So my personal take would be that an electroretinogram is mandatory before we kind of even decide about what we are talking about. Because if I am going to tell you your patient is probably having a chirpy, which is a grouped chirpy, how will you defend it? Congenital hypertrophic retinal pigment epithelium. You tend to have hyperplasia everywhere. It's a grouped chirpy. So if I say grouped chirpy, that again will have a lot of pigmentations. How will you defend to say that, yes, this is not?
Ma'am, just by ERG.
Yeah, so that is what I think it is pretty crucial that we need to have these things. Yeah, when we present a case, we have to have compulsorily all the investigations that is necessary for the case.
Yes, ma'am.
Okay, yeah.
Yes, ma'am.
Thank you. Otherwise, it was very nice discussion actually.
Yes, ma'am.
Thank you, Karneshwari. Dr. Purna, please.
Okay, fine. Give me off fine. First of all, congratulations, Pratna. It's not
Thank you.
easy to present a retinal dystrophy case, that to an atypical case.
Yes,
These are the kind of cases even when the retina specialist struggle to, zero in on. So still we can go on discussing. So excellent attempt. So most important thing is the way you have worked up the case, taking a proper history, drawing a pedigree and all that. So basically, when it comes to inherited retinal dystrophies, the first thing is you should be able to differentiate whether it's a treatable condition or a non-treatable condition. Okay, you should not miss a treatable condition and label it as a dystrophy. Once you label it as a dystrophy, 90% of your job is done. So in 10%, you need to differentiate further. The reason being, you need to explain the prognosis. I think there is no treatment. Somebody was asking, because both are there, what will you do and all that. So, so the way the patient is going to choose his career, the way he's going to handle routine things, okay, what he's going to plan for the future, everything depends on the kind of prognosis you have. And all retinal dystrophies may not have the same prognosis.
Yes,
That is
ma'am.
very important. And also this is extremely important because I know I have many RP patients who are cab drivers. They tell sir, मैं चले तो रात में बनाना, and it's our responsibility to guide them. As a doctors, we treat patient, we diagnose, we do surgeries and all that, which is a very easy thing. But the toughest situation is when there is no treatment. Okay?
Yes, sir.
Because it is not only a burden for the patient, it's also for the family members. The way you counsel them, pinpoint, that becomes extremely important. That is one thing you need to prognosticate by pinpointing the diagnosis.
Yes, sir.
The second important thing is the awareness about genetic testing, which you already mentioned, it's also important that we should stop this transmitting to the next generation. Okay. You need to
Yes,
give
sir.
them the genetic counseling. There are many methods to do that now. We can go for embryo selection, prenatal diagnosis. We can do amniocentesis, CVS, and all that. Amniocentesis is more than enough. CVS may not be all the time. That is one thing. And
Yes.
regarding ERG and why it's not acquired, or why it's an may genetic disorder. If you look at the fundus photograph, first thing is it's very similar. Okay, so
Yes,
that
sir.
right on the fulfilled photograph, that is very in favor and early onset of disease. Okay, so that is. And regarding broad cone dystrophy and RP, somebody was asking. See, RP is also nothing but it's a type of broad cone dystrophy. Okay. Broad cone dystrophies are nothing but a group of disorder where the degeneration starts in the periphery, involving the broad predominant area, then progress to the center, eventually involve the macula like that. In your case, atypical thing was the macula was involved. This is
Yes,
not the
sir.
case in a case of typical RP.
Hmm.
So once the macula is, see, the thing is, these are all the older terminologies which have been used, like RP, inverse RP, RP, giant pigmentosa. So what is the latest thing what we use for inherited dystrophies? We always want to do a genetic testing and label with the mutation is possible. Okay, so that's
Yes,
your
sir.
final diagnosis. Okay, so and it
Yes,
could
sir.
be your the case could be a choroidal dystrophy also. If you look at as someone was pointing out, there is not that much of a gross arterial attenuation, there's not much of a vaccipala which is not present. Okay, some of the choroidal
Yes.
dystrophies also can present like this. And to answer that vitamin A related question, see, vitamin A deficiency will not have any structural changes. Yeah, there won't be this much of degenerative changes.
Yes, sir.
Most of the patients who are chronic alcoholics with irritable bowel syndrome, inflammatory bowel syndrome, present and all that, initial stage they will have a normal appearing fundus. Only
Normal.
thing what can pick up is ERG. Okay, and we can supplement it and it will have a will have a I mean, it can be reversed. The changes can be reversed. Okay? And regarding fulfilled ERG, see, ERG is something where we are not able to understand things structurally. We are seeing something. If you are not able to understand, then you go for the ERG. Otherwise, CRG is not available everywhere, right? Not tell
Yes.
like you have to. Of course, for the case presentation, it's good that you have everything. But if something is very typical and all that you're diagnosing it and all that, unless it's going to add, diagnostic or prognostic value, it's not a must. Okay? Like for example, in Stargardt disease, somebody was asking, ERG can have a prognostic value. Yes, like early Stargardts, the fulfilled ERG can be normal. That means the disease is limited to the macula, in which the prognosis is good. Both cones and rods are affected, the prognosis is bad. And this case can be a differential diagnosis for Stargardts. The reason being, when a very advanced case of Stargardts can mimic RP. Early stage, you will have beaten bronze appearance and all that. In advanced stage, when there is a degeneration is quite extensive, you can have these kind of bone speckle pigmentation and all that. So basically, to summarize, hope I have covered all the question. In case if I missed, you can please ask me again. So to summarize, it's very important to diagnose and not to mislabel this treatable condition as dystrophy. Next, to prognosticate, do a deeper phenotyping by doing an autofluorescence, OCT, ERG, and genetics. Should put everything together, then counsel the patient. And you should never forget to send them for a visual rehabilitation. That is extremely important. Treatment management doesn't mean that you do laser, surgery, injection, and all that. Because visual rehabilitation becomes extremely important. I have patients who are doing really well once you tell them what are their limitations, what should be done, and all that. It's a very tricky situation. Otherwise, in Indian context, most of the time, they'll be under a lot of pressure, and acquired blindness is not an easy thing to handle. So, but if you counsel them well, if you tell them what they should do, what they should avoid, the quality of life can definitely. Okay?
Yes.
Hope I've answered. So please,
Thank
if I
you.
missed anything, please you can ask.
All the points have been well taken up, and I
One
think
thing I would just like to say, yeah, everything is well covered. One thing I was wanting to make a point is like you took very nice history of hearing loss. That's it. But once you should not miss something which is a treatable cause of retinitis pigmentosa, especially in atypical cases. So do have phytanic acid deficiency, refsum disease in mind, and A beta lipoproteinemia. So history regarding this should also be taken from the patient once you are dealing with the case of retinitis pigmentosa.
Yes, ma'am.
And I will ask Dr. Na, because he's the electrophysiology expert, to pick up one person from the inner circle or outer circle, one person who asked the best question.
I think the person who asked how to differentiate between the Stargardts and this.
Yes.
Sorry, I don't remember that person. That
It
was
is
quite
from someone
tricky and
who asked
That was Neha Chaudhary.
Neha
Outer
Chaudhary.
cycle.
Outer
Inner,
circle.
yeah.
inner circle.
some-
Inner circle. Yes, ma'am. Yes, Neha.
So use that.
Neha Chaudhary.
Yes, ma'am. Yes,
From
ma'am.
which? Neha Chaudhary is from where?
Thank you, ma'am.
Neha Chaudhary is from Jamshedpur, MGM.
Yes, ma'am. Yes, ma'am.
So you have to come on 18th for the collection of the prize.
Okay. Thank you.
And there for LDP also we had two winners. One is local from RIMS, Dr. Anamika, and another is Ujwal. Ujwal is also from which place? Bokaro. Okay, so your question was the best. And you
One from outer circle, Dr. Bharti. One from outer circle, she is from inner circle. One
अभी
One
हमारे
from
पास
outer.
एक ही है for एक ही है जो one is enough for
Okay, Dr. Bharti. Can we move on to next presentation?
Yes, Dr. Ishad.
Yes,
Dr.
ma'am.
Ishad,
Good evening.
please share your screen. And we would like to have Dr. Pratyusha's comment on Irshad's presentation on the first when we are taking expert comments. Please, Dr. Pratyusha, please be ready.
Sure, Dr. Shweta.
Yes, Dr. Irshad, please start.
Yes, ma'am. Good evening, everyone. Myself, Dr. Irshad. I'm here to present a tale of rare retinal vasculitis. So let's start the case. We have a 16-year-old female who was immunocompetent, presented in a OPD with a complaint of diminution of vision in right eye since 2 weeks. Her diminution of vision was in right eye was gradual, and her visual acuity in right eye was 6/60, and left eye was perfectly normal, 6/6. We asked about the past history. She had a history of fever 1 week back, and she took medicine for the same, and her family history was not significant. We did general examination. Patient was alert, conscious, oriented with time, place, and person. Her pellar, sinus, icterus, clubbing, everything was absent. No history of weight loss. Her vitals was within normal limit. And one positive finding was she had her body temperature was raised. On ocular examination, her pupil size shape was normal. Ocular movement was full free and painless. RAPD was absent. Intraocular pressure was within normal limit, and her color vision was within normal limit. We did slit lamp examination. On slit lamp examination, lid, conjunctiva, everything was normal. Anterior chamber was quiet. Cornea was clear. Lens was clear. Iris was within normal limit. On fundus examination, vitritis was present and perivascular sheathing of retinal vessels. Then we did fundus photographic imaging. Here we can see the diffuse translucent perivascular sheeting of retinal vessels, which actually looks like a frost tree branch covered with the snow. Actually, this is what look like a frost tree branch, which looks like a covered with the snow. Here we can see the fundus photo. Then her left eye was within normal limit. Then we did a optical coherence tomography OCT. Here we can see the macular edema in right eye, and her left eye was within normal limit. So this was the main reason of her reduced vision. Then we did lab investigation to rule out other inflammatory and systemic illness like CBC-SR, CRP, torch, cytomegalovirus, ANA. To rule out TB, we did quantiferon gold. Then we did chest X-ray. One of our positive finding was serum cytomegalovirus IgM was positive. Lymphocytes, CRP, and ESR was raised. So our differential diagnosis are these are our differential diagnosis. Cytomegalovirus, acute renal necrosis, and toxoplasmosis. Let us rule out one by one our differential diagnosis. First, cytomegalovirus. Cytomegalovirus mainly occur in immunocompromised patient, and it is associated with necrotizing retinitis and hemorrhages. But in our case, these kind of observations findings are not visible. And also in cytomegalovirus retinal, we see a classical pizza pie appearance, which was absent in our case. So cytomegalovirus is ruled out. Next is acute retinal necrosis. In acute retinal necrosis, here we can see severe vitritis and severe pain, which actually leads to RD. And and mostly here the peripheral, we can see the peripheral necrotizing retinitis in this case. And these findings are absent in our case. So acute retinal necrosis are ruled out. Next is toxoplasmosis. First history asks about do you have a pet or cat in your home? But it was no negative finding was there. But in toxoplasmosis, focal lesions are present, and in our case, diffuse lesion was present. And in toxoplasmosis, headlight in fog classical appearance present, but here these kind of findings are not visible. So toxoplasmosis is ruled out. Next is Becher disease. In Becher disease, it is also kind of retinal vasculitis, but it is associated with oral and genital ulcers. In our patient, these kind of findings are absent. So, and uh, uh, in Becher disease, vasculitis is occlusive, but in our case, it is uniform and diffuse. So, Becher disease is ruled out. Next is Eales disease. Most important is Eales disease. In Eales disease, mostly peripheral retina is involved, and here in our case, central part of retina is involved, and in Eales disease, there we can see a segmental involvement. But in our case, there is diffuse involvement, and Eales disease is chronic, but our patient is complaining about a vision loss, which is acute case. So so Eales disease is ruled out. Next is ocular tuberculosis. As ocular tuberculosis is also segmental and patchy appearance is seen on fundus, but in our case, diffuse findings is observed. And also our TB interferon is negative. So ocular TB is also ruled out. So we come to a provisional diagnosis: unilateral frost bronchitis, which is secondary to cytomegalovirus, which is the most common cause of frost bronchitis due to cytomegalovirus infection. So treatment. After confirming the cytomegalovirus, we started antiviral therapy, then followed by later oral corticosteroid therapy to reduce the edema, along with symptomatic treatment. So patient came back for follow-up after 15 days. Here we can see the fundus photo, right? Here we can see the resolved frost bronchitis, and her visual acuity significantly improved from 6/6 to 6/9. And her left eye was still uninvolved and within normal limit. And we did OCT. Here we can see the reduced macular edema, and left eye was still within normal limit. So, now this is a summary of my case. We have a 16-year-old immunocompetent female with DOV in right eye. We did a fundus examination, and we saw perivascular sheathing of retinal vessels, which of retinal arteries and veins, which looks like Foch bronchitis, which is suggestive of Foch bronchitis. We did OCT central retina, where we saw macular edema in right eye only. Then post laboratory confirmation of CMV, and we started systemic antiviral. Later, subsequent oral corticosteroid therapy was also given. Post treatment, we saw fundus photograph which show resolved Foch bronchitis and suggestive of Foch bronchitis and decreased macular edema. So our final finding is most important thing, her visual acuity improved from 660 to 6/9 on follow-up. So conclusion: Foch bronchitis in adolescent can occur secondary to cytomegalovirus, which is the most common cause, despite being immunocompetent. And Foch bronchitis is mostly bilateral, but in our case, this is unilateral, which makes this case unique. So in this case was unilateral presentation, and Foch bronchitis also signals possible systemic disease. So we have to rule all the systemic disease by doing lab work. So early diagnosis and timely treatment are critical for favorable systemic and visual outcome. These are my references from standard textbooks and some article. Thank you.
Thank you, Dr. Irshad, for a wonderful presentation. And now the case is open for discussion, and we can have participants from inner circle to question Dr. Irshad. So who is going to start the discussion? I could see Dr. Mayank has joined from inner circle. Dr. Mayank, you have not asked in the previous round. Would you like to ask some question from Dr. Irshad? Dr. Mayank, yes, please. You can switch on your video so that we can have a better interaction. Yes, please. Please ask your question.
Hello, ma'am. I'm Mainsan from MGM Jamshedpur. I want to ask if we can think of HIV retinopathy as a differential diagnosis in this case.
Yes, sir, we can think, but we have ruled out by doing laboratory investigation. We have done HIV, HBsAg, everything. Everything was not negative.
Okay. Anyone else would like to ask some question?
Good morning, everyone.
Yes, Amar. Yes, please.
Amar from MGM Jamshedpur. I want to know that what are the key imaging features on FFA to distinguish between frosted branch angiitis from Eales disease?
Yes, sir. So in FFA, we will see the diffuse vascular leakage in both arteries and vein. But in Eales disease, only veins are involved. And also in Eales disease, we will see the extensive CNP areas, which are absent in, which are rare in FBA. So the takeaway point is in FBA, both arteries and veins are involved, but in Eales disease, only veins are involved.
Okay, thank you.
Thank you, Dr. Amar. So anyone else who would like to ask the question?
Ma'am, hello. I just
Yes,
wanted
ma'am.
to ask few questions.
Yes, please.
Why veins are prominently involved in arteries in this disease, ma'am, FPA, and what is the reason behind it? And I also wanted to know about the macular complications involved in this disease. So these are the questions.
Ma'am,
Other
due to
macular.
inflammation of retinal vessels, there is damage to endothelium. And due to this damage, fluid leakage, there is leakage of fluid, and due to increased permeability, and there is leakage of fluid, this causes macular edema. And this is the main cause of decrease in vision.
Okay.
And another question is, ma'am, retinal veins are
Why
thinner.
veins are prominently involved than arteries in this
Ma'am,
disease?
arteries are thick muscular walls, and they
Okay,
are
fine.
more resistant to inflammation. But veins are less smooth and less elastic tissue. That's why
Overflow.
veins are more involved.
Okay. And which systemic diseases should be ruled out in this case? What are the other systemic diseases more
Ma'am,
prominent?
systemic diseases like CMV, HIV, HBsAg, and other sarcoidosis. Then all the infectious cause like SLE, then
Behçet's disease, SLE.
HS disease. We have ruled out by because she was not having any kind of oral or genital ulcer.
Okay, thank you.
Okay, Dr. Lalita, let's move on to the outer circle. Who would like to ask the question? Dr. Gagandeep, are you ready with your question?
Yes, ma'am. As
Yes,
we see,
please.
the CNP areas are often limited, although the sheathing in frosted bronchitis is quite extensive. So why is that? Why is CNP area still limited?
Sorry?
CNP areas, why is it so limited? While the sheathing is quite extensive, it's a diffuse disease. Why is the CNP area limited?
Like in Eales disease, you will see the extensive CNP area because then mostly veins are involved. But here, both artery and veins are involved.
No, I understand that, but it's because it's not an occlusive disease, right?
It is a perivascular inflammation, and in
Perivascular inflammation.
you
That's
can
why
see the
there's no
sheathing and leakage.
obstruction of the flow itself.
There is no obstruction because it is perivascular disease, and perivascular means vein vessels के बाहर, not under. So it's not
Exactly.
occlusive. It is perivascular
Hence,
disease.
we do not see a large amount of CNPs areas.
Yeah.
So very good, Dr. Irshad, for wonderfully answering the questions. Anyone from outer circle? Dr. Vatsala, Ujla, Shubham, Anamika, you would like to ask some question?
Dr. Irshad,
Yes,
firstly,
please.
a very nice presentation. I just wanted to ask 2, 3 basic questions. Like the first one is, which systemic antiviral did you start, and what was the dosing of the same? And secondly, yeah, you can go ahead.
Ma'am, we have two options. Mostly for CMV, we use ganciclovir and valganciclovir. Valganciclovir is a product of ganciclovir. But here the patient is stable. That's why we use valganciclovir, whose dosage is 900 mg per day. So we have a tablet in market, 400 mg. So we have given 400 mg BD.
Okay. My second question is, why was the steroid started later, as in a week later?
Ma'am, if we will start it earlier, it will worsen the condition because the patient is already having a cytomegalovirus infection. So she is a little bit thoda sa immunocompromised. So it will worsen the condition. That's why we have given under the cover of antiviral. After 7 days, we have started the steroid.
And the last question is, what is the basic pathophysiology that the vessels look frosted? I mean, why is it called frosted?
Because it is a perivascular disease due to accumulation of exudates around the vessels. It is looking like a branch where many snow are getting accumulated.
Oh, thank you and all the best.
Thank you.
And Dr. Irshad, I would just like to add and ask you that what are the other causes which can lead to this condition? And why was the more the inclination towards the infective cause and not an occlusive cause? Because sheathing is there. And why? What are the other causes which can cause a similar picture in the retina? And why was your diagnosis more towards an infective cause? And how could you differentiate it from an occlusive disease?
Ma'am, we can differentiate by using FFA, and we have done
Clinically, any science, clinically, FFA is of course there, but clinically, by just looking at the fundus, is there any way in which we can differentiate it?
we can see the like sheathing around the vessels, and
Okay.
And clinically, ma'am, can you repeat the question?
Yeah, how can you differentiate it clinically from an occlusive disease, not by using FFA, just by say looking at the fundus, or by looking at the anterior segment examinations or any other fundus examination or systemic examinations which you have done?
Ma'am, other systemic examination, like we have asked everything about like any kind of rash or loss of body weight, and that will rule other the causes. Like we have we have asked about malar rash or other rash to rule out SLE. We have asked about
Yes,
genital
sure.
ulcer or oral ulcer to rule out Behçet disease, and we have asked about the recent loss of body weight to rule out HIV or tuberculosis. And also on the
Okay,
basis,
okay.
yes, ma'am.
Thank you.
So let's see what experts have to add to Irshad's presentation. Dr. Pratyusha?
Dr. Irshad, a very good attempt. I think you tried your best, in this. A couple of things. You think really CMV treatment was necessary in this patient?
Yes, because IgM was positive, not IgG. So she was having current active infection.
So just serum IgM coming positive in CMV is sufficient to say that the patient is having infection?
Ma'am, we could have done like a PCR of AC tap that will confirm a diagnosis, but we haven't done that.
So there are also other ability tests that you have to do before you can confirm that this is CMV related. And the second thing is that somewhere you said patient is immunocompetent, and then you said she's probably a little bit immunosuppressed. So the main thing you need to differentiate. Tell me.
Like she was currently having fever and other thing. That's why, and she was like not severe, like she was comfortable at home. Everything, the infection was not severe. That is why we didn't start IV because she was not admitted. That's
So what
why
did you give? You gave oral?
Oral medication, yes.
Okay. So the main thing is that you need to be very clear whether your patient is immunosuppressed or immunocompetent. Okay. So when you're talking about immunosuppressed and CMV infection, it is mainly the CMV virus infecting the endothelial cells of the retinal veins. But when you're talking in an immunocompetent person, it's mostly we are talking about an immune complex mediated disease. So these are two entirely different things. So it's not very easy to manage this frosted branch angiitis related to CMV in a HIV patient as against an immunocompetent patient. So it's an immunocompetent, you give steroids and you see an excellent response in these frosted branch angiitis patients, right? So you need to be
Yes,
very
ma'am.
clear what you are dealing with, right? You are doing so many investigations like CBC, peripheral smear, and all these things are basically to see what is the immune status of the patient. You can see the WBC counts, the lymphocyte counts, and other things. So what
Yes,
I want to
ma'am.
tell you is that basically when your uveitis is a very complex disease, many a times you get positive results which don't make any sense. Sometimes you get results you don't get results positive when you're expecting that a certain disease is going to cause this particular form of uveitis. Okay, so you need to be very patient, and very important is to have a good clinical acumen. Okay, so in this condition, for example, this process, you had so many differential diagnoses, right? So you could have usually sarcoidosis, what you have put in one of your differentials, usually presents with periphlebitis. Okay, and also you see in those peripheral regions, you see some snowballs and some granulomas and other things in sarcoidosis, which usually you don't see when it is this viral related thing. And syphilis, what you put, basically there it's more of a periarteritis. You're talking about SLE. SLE most commonly is presents with hemorrhages, cotton wool spots, and capillary non-perfusion areas, new vessels, and these things, right? Again, tuberculosis, it produces very focal perivascular venous sheathing. It's not like these diffuse and a long lens of perivascular sheathing which you're seeing from the posterior pole going all the way up to the mid periphery and beyond. So a good clinical examination itself will help you rule out a lot of diagnosis. Okay, and every investigation that comes positive in uveitis, you don't have to jump in and make it the etiology of that uveitis. That's what I'm trying to say. Okay.
Okay, ma'am. Yes, ma'am.
Thank you, Dr. Pratyusha. And since we are running out of time, we can, I think, since we had a good discussion, can I request Dr. Sugneshwari to announce the best question from all the questions that were put by the inner and outer circle? Dr.
Yeah,
Sugneshwari?
it was actually a wonderful discussion. Only one thing I just wanted to say was like syphilis is one thing which Dr. Pratyusha pointed out. It was a good point. But yet another thing I would like to tell is, most importantly, you did not have a single hemorrhage in the retina. So
Yes, ma'am.
that itself rules out that you probably had any event of a retinitis in your patient. So what you probably had was only an immune mediated response to a fever, because she is a young girl. She's a 16-year-old girl. So in a 16-year-old girl, if you get a response like this, if you are thinking in terms of a CME, you could ask for a urine quantitative PCR, where you can quantify the number of copies that is there. If not an aqueous, you can even do, because if she had had a systemic CMV, she will 100% be excreting the virus also. So you can do what is called as copy number. And the second thing is, an infectious disease consultant has to be he or she has to be taken into this one cross consultation. Without that, starting a patient on acyclovir is not a good idea, because see, one thing is a CMV will not melt away within 15 days. What you saw in the patient was within 15 days, there was no clue on the fundus, meaning the whole thing has melted. It's become a normal fundus. It has become a 6/9 vision. And your patient had a macular edema. So which also suggests that she was very highly immunocompetent. And what she was throwing was, because you said there was a history of fever for that girl, her body temperature was high. So she must have had an episode wherein she had reacted. So most likely these patients respond only to steroids itself. Oral steroids is most important. And yet another thing also, a bacterial cause also can cause this kind. You can also have, see, for instance, you can go through the article on RCBR, which I published. If you put my name, you will see an FBA, post-intravitreal injection, who had a branch retinal vein occlusion and then had an intravitreal injection. She developed an FBA. So these are certain things which are post-infective. Since, of course, post-injection, she had an infection to streptococcus. So you can have these kind of entities also, which could camouflage your picture. So a CMV has to be treated only if it is proven a CMV, not otherwise. Because otherwise you kind of brand them and then they will be on, because CMV retinitis treatment is a prolonged course. And for a 16-year-old, we have to be very, very judgmental. Now to the question, who has given the best question is Dr. Gagandeep, who had asked on how do you, why was there an extensive sheathing and why is the CNP area is limited? I think his question is very valid in the context of this particular case. So I would feel that Dr. Gagandeep deserves the award for this one. Yes.
Thank you, ma'am.
Congratulations,
Thank you so much.
Dr. Gagandeep, and I must appreciate all the experts for such excellent guidance and such clarity of thoughts that they have shared during the session, and it is beneficial to each one of us. The mentors are also over here. We can see Dr. Sophia Ahmed over here, Dr. Rahul, and all sitting late night just listening the discussion. I must thank everyone, and special thanks to Dr. Bharti. Over to you, Dr. Bharti, for further moderation. Dr. Bharti.
Can I ask a question to Dr. Purnachand regarding ERG?
Yes, please, Dr. Sophia, you
Yes.
can. Dr. Purna is here.
So, while doing ERG, if the patient is uncooperative, can the results be reliable?
So you are starting discussion. So did you pick up the best discussion from Dr. Irshad's session?
So it was Dr. Gagandeep. Dr. Subrameshwari announced that
Okay.
Dr. Gagandeep.
Actually, I was discussing some about midterm conference. There is a lot of lot going, lot going. Yes. Okay.
It's okay, ma'am.
So we are organizing team now. So there was a lot of things going on. I was just reading. Okay.
I had a question for Dr. Purnachand.
There are a lot of discussions for Dr. Purna, for Dr. Signeshwari,
Yes.
and I can see
That's
Dr.
what I'm thinking.
also.
Regarding ERG, if the patient is uncooperative, will the results of ERG be reliable? Because most of the time, this is an objective test, and what the patients see that, like we have patients of unexplained visual loss. Everything is normal, fundus is normal, everything is normal. So we get an ERG done. So if the patient is not cooperating at that time, will the result be reliable for the patient?
So see, if the patient is not cooperative, it can definitely the results can get affected. So the ERG, the basic thing, the moment you start interpreting the waveforms, is always like I mean, it's kind of taken for granted that ERG is being done in an ideal situation, following
Yes.
ISAF standard, and the patient was cooperative and all that. But the situation what you are telling, it is possible in children and also patient who are malignant.
Yes.
So in
Most of the
children,
malignant patients, they don't fix
exactly.
it.
So in these two cases, it's very tricky. Your ERG technician has to be little intelligent to make them so cooperative. This thing. So hello, can you hear me?
Actually, Dr. Bharti is speaking. Yes, go.
The
Please
host
carry.
can make. Yeah. So the thing is, what I was trying to tell is the technician has to be little intelligent. First thing, if it's a children, to make them really cooperative, you can make them, show them the images of other children being getting examined.
Yes, yes.
And also there are some shoulder spins which are available so that they don't remove the electrodes. So
Okay.
that is one thing. And in case of malingering patients, it's easy. I mean, basically when you're giving a stimulus, make sure that the patient has to see. Even if the patient sees once either the flash stimulus or a pattern, it will give us the recording. Okay. So the
Flash
pattern.
ERG is better for them.
Yes, flash ERG is better. The pattern ERG can be fake. For example, if you're giving a pattern, if the patient is not concentrating, still you can get an abnormal value. In that way, so there is a system to monitor. You're doing an ERG, there is a camera which get displayed, which will, shows where the patient is. Once the patient is looking, even if he's not concentrating, the moment the light falls or the image falls on the retina, you'll get an recordings. Okay. So that becomes little easier, when it comes to picking. Malingering is very easy. Most of the time when you do the malingering test, you'll get
Because
it.
many of our patients are
Yes.
malingering because it is an industrial hospital, so we have to refer them. So it comes in the comment that patient was not cooperative. So it is difficult to interpret those findings also at that time.
If the patient is not cooperating, most of the time it's malingering.
Yes.
And why will a patient who has a genuine problem will not cooperate? I mean, I'm talking about the adult patient. So the fact that it's not cooperating is not able to see. If you are 90% sure that it's a meningitis. Okay. So
Okay.
unless patient has, because of some syndromic association as a limitation and all that, that is one thing. And we avoid doing and in fact, we have stopped doing, ERGs under general anesthesia because that itself can be a confounding factor.
Okay. Thank you.
I'm really sorry. I just went to discuss with the OBSC group for the forthcoming midterm conference. I'm really sorry. So, Dr. Sophia, are you here? Dr. Sophia?
Yes, I'm here.
Okay, you can give vote of thanks. You are institutional head. You are heading Bokaro General Hospital, and DNB courses came much after later to other institutions. You were first among the those institutions who have PG teaching. How did you like the fishbowl? How did you like the Retina CME by the national stalwarts? Do you think it was how useful was it? Please give the vote of thanks and your opinion also. Dr. Kashyap, are you here?
First, I would like to thank all the PG students who actively participated, and it was an excellent presentation from both the students. And such nice questions were coming from the PG students. They were really interested and they had read the topic. And the discussion was also done by the panelists, senior Dr. Subneshwari, Dr. Pratyush, and Dr. Punachand. They almost cleared every doubt, and all the questions were answered very well. And this was a very interactive session. So next time when these students join, they'll know what to do, and they will have more active participation. And thank you all from on behalf of Jharkhand Ophthalmological Society. Thank you so much.
Thank you so much. Thank you so much, and especially for staying so long. For staying so long.
Yes,
I'm
yes.
really
Takes
thankful.
so long.
And for to Dr. Sugneshwari, Dr. Pratyusha, Dr. Subina, Dr. Purna. Actually, I added Dr. Purna's name because there was a talk on electrophysiology. So this case involved electrophysiology. So though he was not very well versed with the fish bowl, but I was also thinking, what is this fish bowl? But I really found it very interesting. Any postgraduate student, Ujjwal, तुमको कैसा लगा? बताओ. How did you like this fish bowl?
Ma'am, I like the fishbowl. Uh,
इसमें
I
तुमको
would,
क्या अच्छा लगा?
ma'am, the presentation was very comprehensive. Everyone was participating. I also wish to add in a typical RP, to families to be counseled is very important, because the symptoms they don't get to know na matlab, uh, the peripheral wheel loss, nyctalopia, these are very matlab, the matlab the family members don't get to, so regular counseling follow up is very important.
नहीं वो मैं समझ गई।
हाँ
ये
हाँ हाँ,
फिश
yes
बोल
ma'am.
का कॉन्सेप्ट तुम लोग को कैसा, गगनदीप? ये
Yes,
कौन है?
ma'am.
तुम लोग को यहाँ आई कैन सी समवन बट उसका नाम नहीं दिख रहा है, जूम यूजर। Then I can, they have not written their name, so but their camera is on, so this concept you like na? Actually I am getting lot of calls, Sugneshwari, from Dr. Partha and all for this midterm AIOS. पार्थो 2 मिनट में कॉल कर रहे हैं, 2 मिनट, मेरा midterm ये मीटिंग खत्म हो रहा है। When we call, invite you guys, you please take your time out. You have taken a lot of time out for our postgraduate students. And best part, nobody is an election campaigner. Everybody has done academics for our postgraduate students. So thank you so much. सीमा, कैसा लगा? अच्छा लगा? Thank you.
It was very nice. I really like the concept. इस तरीके का डिस्कशन बहुत मतलब
नेक्स्ट टाइम करेंगे, नेक्स्ट टाइम तुम्हारा नेक्स्ट टाइम करेंगे। एंड नाउ आई एम लीविंग एंड थैंक यू ऑल, बिकॉज हमारा वो चल रहा है बहुत ज्यादा डिस्कशन अभी।
Thank you and good night.
थैंक यू, गुड नाइट।
Thank you, ma'am. Good night, ma'am.
Good night.